Hi, how are you doing?
Good, good. How are you, doctor?
Wonderful. Can you hear me okay?
Yes.
Let me share the screen with you and let me know if you can see my screen.
Yes, we can.
Wonderful. Wait for a few minutes for other people to join.
Dr. Gohar, do you mind reminding us with the schedule for today?
Sure. You see the schedule?
Yes.
Unfortunately, you will have a lot of me today. So mainly, we'll have 3 different topics today: the ventilator management and endocrine emergencies. Then we'll talk about different types of pneumonia.
Sounds good.
Wonderful. May I ask people who joined if we can join with video? Would be wonderful if possible, so we can interact together. Pritham, looks like you are in your car, so be careful when you are driving.
Thank you.
You're welcome. I'll wait for a couple of minutes, then we will start. I think most of the people already joined. I just give one more minute, then we will start immediately. Okay, good afternoon, everybody. Thank you for coming in time. Today, will be the schedule for today. It's from now till 2 p.m. We'll have a ventilator management session. I will talk about ventilator management. Some of you heard that during ICU rotation from me, we had some short lecture about that in July, emergency lectures. And after that, hour and a half for Dr. Waidi to talk about endocrine emergencies. Then we'll have a few minutes of break. Then we will talk about pneumonia. We'll talk about the community-acquired, hospital-acquired, and ventilator-associated pneumonia. And I added some slides for the COVID because we had some COVID patients previously. I'm glad that things are slower now, but in case anything worse happens, we'll have some idea at least where to look at the management for COVID patients for inpatient. Okay, I will stop the share, then I will start sharing the slides with you for the ventilator management. Okay. Okay, so this is my email if anybody would like to communicate with me after the course, if you have any questions. And as Bree sent you the email that the recorded course will be on the SharePoint under a folder with the critical care course. And you will be able to access this recorded videos up to 180 days, so for 6 months. We'll try to work on finding a way to keep the recording after the 180 days, but Zoom gave us only 180 days, then the recording will not be accessible. Okay, do you see my slides moving? Looks like yes. So I have no financial disclosure. So the objectives from these 2 hours, mainly we would like to recognize what initial settings that you need to start for every patient. We'll talk a little bit about different major types of ventilator modes. We'll start to talk about how to manage overnight problems that you may be called about. We'll talk about 4 problems: hypoxemia, hypercarbia, high pressures on the ventilator, and hypotension from vent settings. Then the last portion will be how to manage to wean the patient from ventilator and how to liberate them from ventilator. There's a difference between weaning and liberation. Weaning means patient on high setting, and you are trying to gradually reduce the setting. This is the weaning of the setting. When they are ready to be extubated, you do the trial and liberate them from ventilator. I'll start with 3 concepts or 3 definitions I want you to be aware about when we talk about ventilator settings. Triggering. By triggering, we talk about who starts the breath. Is it the patient? We call that he is assisting, or this is the ventilator is controlling everything. We call that this is controlled. Target. By the target, we have 2 main targets. Either we are targeting the tidal volume, and we call it volume targeted, or we are targeting the pressure, we call it pressure targeted. Third definition I would like you to know about is what we mean by cycling. By cycling, what we mean is what ends your inspiration to start the expiration. This is the cycling. And in volume controlled or volume assist, volume targeted ventilation, after your patient gets the tidal volume that you set, the inspiration will end and expiration will start. If you are on pressure limited or pressure targeted ventilator, you will need to set inspiratory time. After that time, the inspiration will end and expiration will start. For patient on pressure support, what ends the inspiration, we set a target of reduction, how much the inspiratory flow goes down from the maximum inspiratory flow. And usually we said that when the inspiratory flow is reduced to 25% of the maximum inspiratory flow, inspiration will end and expiration will start. So this is what we mean by these three words: triggering, target, and cycling. Okay, so definitely we will have CMV, or controlled mechanical ventilation, if the patient is completely not participating in the minute ventilation. And this happens significantly in patients with deep sedation or paralyzed. If they are paralyzed, they will not initiate any extra breath to increase the minute ventilation more than the set minute ventilation for the ventilator. This can happen also with some people who have some central events that not allow them to start the breath. For assist control, the patient is lightly sedated and he can initiate extra breath more than the setting. And in this condition, he can create minute ventilation higher than the set minute ventilation on the ventilator. Minute ventilation is mainly your respiratory rate times your tidal volume in liters. This is your minute ventilation. So assist means your patient is starting some of the breath, adding extra minute ventilation to the minute ventilation that you already set. Controlled means your patient is following your ventilator 100%, and he's not creating any extra breath or any extra minute ventilation. So we have volume targeted or volume limited. In this condition, we set a specific tidal volume, and this can be volume control. Patient is deeply sedated or paralyzed, not pulling any extra breath, or volume assess. Your patient is lightly sedated and he's pulling some extra breath. Same thing for the pressure limited or pressure targeted. We set a specific inspiratory pressure, and the patient can be controlled, pressure control, if he is not doing any extra minute ventilation in case he's deeply sedated or paralyzed, or he's pressure assist if the patient is doing some extra minute ventilation by pulling extra breath. Any questions till now? If you have any questions, please unmute yourself and ask in the middle. I will be happy to answer any questions. If you are not participating in any discussion, please stay on mute. Okay, type of ventilation. Another type is what you call the pressure support. And the pressure support, we use it frequently when we are trying to wean the patient or do the pressure support trial to extubate the patient. So this is something that we usually do. And this can be different pressure and different PEEP. You can have 0 PEEP and just use pressure support, or you can have PEEP of 5 or so and do pressure support. We usually, for our patients with the trials, as we will talk at the end of the 2 hours, when we are talking about weaning, we usually do pressure support here 5/5. What does it mean 5/5? 5 pressure support over the 5 of PEEP. So during aspiration, patient will get 10 centimeter water. Your patient needs to be awake. If your patient does not start the breath, the ventilator will not kick in if you are on the pressure support mode unless you add backup rate. So your patient should be awake. Sometimes during the trial, they tell you a patient has apneic alarms on going on. So this is why, because your patient is not awake enough to start the breath. And when you see in the airway pressure, you will have here, the pressure goes down first. This is the patient starting the breath. He will create negative pressure to trigger the ventilator. So if the patient on this mode with no backup rate and he does not trigger, the ventilator will not kick in. So your patient should be awake to be on the pressure support mode. Pressure support, sometimes we use it for chronic vent weaning. Some patient who is on ventilator for a long time, not able to pass the trials repeatedly, you can do some pressure support to train their muscles to gradually wean the pressure support until they are able to come off the ventilator. Again, volume limited versus pressure limited. In the volume limited, we determine the volume and we determine the rate, so we can control the minute ventilation or the minimum ventilation. But the pressure can be very high if your lung is non-compliant. And we talked about the compliance yesterday briefly in the pre-test questions. I will talk a little bit about the compliance. If your lung is non-compliant or very stiff lung, you may have very high pressure with the volume that you have. If your lung is compliant, you will have lower pressures. So compliance is important thing to look at. And the pressure limited, you determine inspiratory pressure, okay? So you control your pressure. So we said yesterday, we don't like plateau pressure to be higher than Anybody?
30.
30 what? Centimeter water. So
Water.
wonderful. So here we set the inspiratory pressure, and we control the peak airway pressure, and the peak airway pressure is always higher than the plateau pressure. How you can guarantee your pressure will not exceed 30 if your peak pressure will not exceed 30? So how do you calculate your peak pressure? Your PEEP plus the inspiratory pressure that you set will be equal to the peak pressure. So if you set your patient on 20 centimeter water inspiratory pressure and you put him on 10 of PEEP, his peak pressure will be 30. So be sure you don't exceed the 30, so your plateau will not exceed the 30. So you control your peak pressure, and by controlling the peak pressure, you control your plateau pressure. But if your lung is very stiff or non-compliant, what your patient will get very small tidal volume. If you to get larger tidal volume, you require these requirements. Your inspiratory pressure, the higher your inspiratory pressure, the larger the volume, but we don't want to exceed the 30 total pressure or peak pressure, so we don't develop some damage to the lung with plateau pressure higher than 30. Also, your resistance in the airway is important to determine the volume, the compliance of the lung, not just the lung, the respiratory system. And we'll talk in the middle of the lecture about the things that affect the pressure. And it's not just the lung, the pleura participate, the body wall participates, the chest wall participates, and the abdominal distension can affect your compliance of the respiratory system. Which is better, volume targeted or pressure targeted? All the studies show no difference in mortality if you use either. No difference in oxygenation or work of breathing. So both are okay. Some things that favor pressure limited, you guarantee that your plateau pressure will not exceed the 30 centimeter water. They may have some studies show that you have equal distribution of your gas in the lungs, so you don't have over distension of part of your lung compared to the other. More synchrony, because patient can control the flow, so they are more synchronous with the pressure control mode or pressure targeted mode. There may be some data that you may be able to extubate a little bit earlier. On the other side, the volume targeted is better controlling the minute ventilation and the tidal volume. In this condition, you can say, oh, patient with ARDS, I want 6 ml per kg ideal body. Then your patient will get the 6 ml per kg ideal body. With the pressure control, you cannot really assess what will be the volume. It's reliable on multiple factors. It ensures minimum minute ventilation, so you ensure that your CO2 will not go very high during the process. Okay, what will you order? So if you are planning to order volume limited, which is most of our patients here on the volume limited, we may have some few on the pressure limited. What you need to order the tidal volume, and we had some idea how much tidal volume we need for ARDS yesterday. Anybody remembers? Sarah, you can unmute yourself to talk. So.
6 kilograms per milligram.
6 ml per kg ideal body weight for, and we'll talk about the initial setting for 4 different diseases that we mostly see them. Thank you, Sarah. So she's okay. So tidal volume, and this tidal volume is based on what disease you are dealing with and based on the ideal body weight. You need to order the PEEP, and more hypoxemic patients will need higher PEEP. And I will talk to you that any hypoxemic patient don't start with PEEP of 5, start with PEEP at least 8, okay? 8 to 10. If FiO2, somebody is hypoxemic 100%, you need to start with 100% oxygen and titrate down if you can. Respiratory rate, and we'll talk about the different rate requirement for different diseases, and the flow. Here, our ventilators, because we are using a little bit modified mode from the volume targeted mode, we use autoflow. So you don't have to order the flow, because all our patients on ventilators here are on autoflow. And this autoflow thing, just you need for your board exam to see what diseases need high flow. And the high flow means shorter inspiration, longer expiration. So mainly you need the high flow for patients who have COPD or asthma exacerbation. Also the DKA patients, because they are air hunger, they need high flow. But autoflow will take care of that. Here on the pressure limited, instead of the tidal volume, you will order the inspiratory pressure. You will order the PEEP. Be sure inspiratory pressure plus PEEP shouldn't exceed much the 30 centimeter water. You order FiO2, you order the rate, then you order the inspiratory time. What time do you need it? And inspiratory time is important to determine the cycling on the pressure limited. What's the advantage of the volume limited? Again, you assure volume, assure minute ventilation, avoid volume trauma. So you don't want high volume and patient with ARDS. Your patient with pressure limited, you guarantee that your plateau pressure will not exceed the 30. We know that is harmful. Assure pressure, but in the meantime, you may not assure a minimum minute ventilation to wash your carbon dioxide if your lung is not compliant. Also here, the patient controls the flow. So patient will be more able to control the flow. So that's why you may get better synchrony with the pressure limited or pressure targeted mode. Any questions up to now? Looks like no. Okay, so lung is a balloon, right? So the lung is full of air. So just I will use a balloon as an example. And this balloon is full of small balloons that are the alveoli. So alveoli like small balloons inside the large balloon, which is the lung. Okay, this was one of the pre-test questions that we had yesterday, the definition of the compliance, and we had the variable answers for that. And I was expecting that every time I give the lecture, if we are not familiar with what's compliance. So compliance is a change in the volume compared to the change in the pressure. This is what we call the pressure time curve. So this is the pressure and this is the time and the volume targeted ventilation. You have the PEEP. When you give the patient the tidal volume that you want, the pressure will go up and peak, then will go down and plateau. This is what we call the peak pressure and the plateau pressure. Then when the patient exhales, the tidal volume that you gave him, he will go back to the peak. If he's auto-peeping, he may go higher than the peak, but this is the normal pressure time curve on the volume targeted curve. This is your peak pressure. This is your plateau pressure. The difference between the peak pressure and the plateau pressure usually is within 5 centimeter water. And always the peak is higher than the plateau. And I will tell you the peak and plateau is the head and the shoulder. This is your peak. This is your plateau. Okay. So always the peak, always your head is above your shoulder, right? So difference between the peak and plateau represents your airway resistance, including your ET tube. So anything that will affect that will increase your peak flow, peak pressure. The plateau minus the PEEP, this is what we call the driving pressure. This is the pressure that's created, or the pressure change that's created from your tidal volume. And this driving pressure is important to give you the tidal volume. But we would like the plateau pressure to be less than 30 centimeter water. Plateau minus the PEEP represents the compliance of the respiratory system. So anything that reduces the compliance will increase your plateau pressure. And we'll talk about that in the second part of the lecture today about things that affect the pressure, the peak, and the plateau. Okay, so if you set somebody on 500 tidal volume and 5 of PEEP, and you measure his plateau pressure, you have to do something to measure it, and I'll show you that how to do it on our ventilators in a few seconds. So 500, the tidal volume, over, if you measure the plateau pressure, and for example, I gave you here is 15. So 500 over 15 minus 5 will give you 50. Normal compliance is close to 100, okay? And the higher, the better. So the higher, the better means your lung is very compliant, and when you give the tidal volume, the pressure didn't go very high and the lung, so it's more compliant, more healthy. This is one of the things that you can follow every day, regardless of the changes you did. If you change the tidal volume, change the PEEP, change the rate, your compliance will stay the same as long as your patient lung stay the same. So this is one good thing that you can use every day to follow your patient. Compliance today is 50, tomorrow is 40, my patient is getting sicker. Today 50, tomorrow 60, he is getting better. So the higher, the better. So you can follow that every day to see your patient is getting better or not. And if it is going down, look what's causing that. Look at your X-ray. Look at what's causing the problem. Do you have any atelectasis? Do you have any pneumothorax? Do you have any other things that made the compliance worse? Okay, this is our ventilator that we use. So this is the newer ventilator, the General Electric that we have in our intensive care here. You see this word here, inspiratory hold. I hope it's clear to you. The inspiratory hold button, this is how you measure the plateau. If you look at the screen, it's giving you the peak. Here is 27, and the plateau, and the median is 14, but it's not giving you the plateau pressure. To get the plateau pressure, you have to push this inspiratory hold. And once you push this inspiratory hold, you will see this green button. You push this green button, the ventilator will measure the plateau pressure for you, okay? And you will see this light blue thing will go up and plateau at a certain point. This is the plateau pressure. Then you will get the reading here. When I measured this patient, plateau pressure was 19, so he is below 30. Look here, your peak pressure is 25. If you are not really planning to calculate the compliance, my peak pressure is 25, then my plateau pressure is less than 25, so I'm okay. Make sense? You really need to measure it if your peak pressure is higher than 30. Then you need to look at, especially if it is 40, 45 or something, you need to look, is it high peak pressure only, or you also have high plateau pressure, and you may need to do certain things to lower the plateau pressure because it can harm the lung of your patient. Okay, what can cause low compliance? Everybody, when you were young, you had a new balloon, right? At a certain point, and you try to blow this or inflate this balloon with your mouth. Now they have pumps and things like that for that to make it easier. But if you try to inflate a new balloon, it's very difficult to inflate. It has a resistance. It is non-compliant balloon, and this is the non-compliant lung. If you inflate this balloon 5-10 times, it will be easier to inflate with less pressure. This is more compliant balloon. So exactly the same on the lung. What can reduce the compliance in the lung? If you have anything inside the alveoli or anything in the interstitium around the alveoli. If you have fluid inside the alveoli, like water in pulmonary edema, pus in pneumonia, blood in alveolar hemorrhage, anything around the alveoli can be something acute, like water in pulmonary edema, can be inflammatory cells in pneumonia, can be fibrosis in IPF. All these people will have low lung compliance. Okay, you remember yesterday that, so get your phones ready. We'll have some questions so we can participate through the poll everywhere. Get your phone. You probably will have it there, but just send the text. If you didn't have it yesterday, send text to this number 37607. The text that you need to send is my first name, my last name 064, and the letter should be in capital. If you had it yesterday, just send that, and this will get you access to the poll everywhere. Okay, somebody sent me B. It's working, okay? Okay, just don't send me for now. I'll clear the responses. Okay, somebody else sent me A. Thank you. I will just wait for a few seconds if anybody did not join. Once you join, just stay there. Okay, I will clear the responses and we'll wait for the questions. Great, we'll start with the first case. I'll read the case for you, then you will send me your answers. 42-year-old man with alcohol-induced pancreatitis developed shortness of breath on the floor, transferred to the ICU. No history of heart disease. On exam, he weighs 100 kilos. This is his actual body weight, but he is 5'10", 5 feet 10 inches, and 178 centimeters. Setting 85% on 100% non-rebreather. Chest has diffuse bilateral crackles anterior and posterior. No gallop on the heart. This is your ABG. pH 722, CO2 60, oxygen 50, and 25 bicarb on 100% non-rebreather. So he is hypoxemic, hypercarbic. Chest X-ray shows bilateral infiltrate, intubated by anesthesia, and RT is asking you for the vent settings. These are your options. Look at those, and once you are ready, send me your answers. A, 600 tidal volume, respiratory rate 14, 100% PEEP of 5. B, 700, 18, 100% PEEP of 7. C, tidal volume 800, respiratory rate of 20, and 100% FI2 PEEP of 8. D, tidal volume 450, and respiratory rate 20, 100%, and PEEP of 8. I just got one answer up till now. This can be everybody is sending the same letter. I hope so. I started to have some other answer. Okay. I have 92% answer D, and only 8% answered C. Okay. So D is the correct answer. This patient has, what do you think he has?
ARDS.
ARDS.
Wonderful. So everybody, he can be something else. When you think about your patients, just create a differential diagnosis. He's probably ARDS because we are talking about the then setting for different disease. But can he be like pneumonia? He has pancreatitis. He's in the hospital. Can be hospital-acquired pneumonia. Can be volume overload. We give a lot of fluids for patients with pancreatitis. Sometimes they develop some renal impairment and they start to get volume overload. So we said ARDS. What are the criteria for ARDS that we talked about yesterday? The modified Berlin criteria.
Has to be
P2
acute.
over FiO2 under 300 on a people 5.
So wonderful. PF ratio less than 300 on people 5 and bilateral chest infiltrate acute within 7. Correct? So what are we missing here? And heart problem is not the cause of the infiltrate. So these are the 5 criteria. What are we missing for this patient? We are missing the
People 5.
Wonderful. And what's his PF ratio? What's the PA2 in the ABG? Usually the third number. 50, and he's on 100% oxygen. So what's PF ratio?
50.
200.
How much? So
50.
PF ratio is PaO2 over FiO2. PaO2 is 50 and FiO2 is 100%. What will be the PF ratio?
50.
50%.
Wonderful. Why 50? Because the 100% is 1. 50 over 1 will be 50. Do you think if you put this patient on people 5, his PF ratio will go from 50 to 300 and something? Usually not. So this patient probably qualifies for ARDS. The only thing he's missing based on the modified Berlin criteria will be the people 5. Okay, he is 100 kilos. So what's his ideal body weight? He is a man, 5'10". We had it in one of the questions yesterday.
73 kilos.
73 kilos times 6 will be close to 50, right? So the small tidal volume, 456 ml per kg, ideal body weight. You see the answer A, if your information is not solid and you 6 ml per kg and he's 100 kilos, then 600. Always on the board, they put you 600 per kg actual body weight as an option. So see if your information is solid or not. Okay, we used D, 450 tidal volume, respiratory rate of 20. We usually use fast respiratory rate to compensate for the small tidal volume so your patient can get reasonable managed ventilation. Patient is hypoxemic. Even on non-rebreather, his oxygen is 50 with 100%, setting 85%. Then your patient, you should start him on 100% FiO2. You should start him on PEEP higher than the 5. I usually start minimum 8 or 10 for patients with hypoxemia. Make sense? So D is the correct answer. Okay. Let me clear the answers to be ready to the next case, but I would like to talk to you about few things that we talked about. So this is the 2000 New England, the ARSNet study, multi-center study mainly based in Canada. 6 ml compared to 12 ml per kg reduced mortality from 40% to 31% to 9% absolute reduction in mortality. So, but in this study also they kept the plateau pressure less than 30. So with 6 ml per kg ideal body weight, plateau pressure was higher than 30, they reduced it to 5. Still higher than 30, they reduced it to 4. Still higher than 30, they switched to pressure controlled mode. This is a modified Berlin, and this is on the lower part of the slide. This is the JAMA reference in 2012. So they modified the definition a little bit. Before that, we had acute lung injury with PF ratio 200 to 300. They made it all below 300 is ARDS. There is no acute lung injury. And they classified in this study the ARDS into 3 groups, mild and moderate and severe, based on the PF ratio. 200 to 300 is mild, 100 to 200 is moderate, less than 100 is severe. And this classification correlated with a couple of things. how many days on ventilator, and the mortality. 5, 7, 9 days, mild 5, moderate 7, severe 9 days. And mortality, you don't have to remember the exact numbers, but close numbers will be 25% mortality, 35% mortality, 45% mortality. And the studies that we'll talk about later, they didn't use this classification. So they said had different classification for the severe ARDS. Okay. When I say like our patient had PF ratio of 50 on no PEEP versus another patient has the same PF ratio of 50 on 15 of PEEP, who's more hypoxemic?
The one who is on 15?
The one on the PEEP, because PEEP helps the hypoxemia, correct? So if you are on higher PEEP, PF ratio is low compared to somebody else on low PEEP or no PEEP, then the one on higher PEEP is more hypoxemic. So this oxygenation index is a different thing that you can follow on the ventilator every day in addition to the compliance. And what they did, they flipped the PF ratio. So now the PO2 is in the bottom and FI2 is in the top, and multiply that in a fixed number, which is 100, and multiply that by times the mean airway pressure. Okay, this, when you get higher PEEP, your mean airway pressure will get higher. So this oxygenation index is another thing that you can use every day. Normal PF ratio is 500. Any one of us, we are breathing room air, 0.2, and we get ABG for any one of us will have 100 oxygen. So 100 over 0.2 will be 500. So between 400 and 500 minimum is the normal PF ratio. Oxygenation index normal is 2 to 3. So the lower, the better. So opposite, because we flip the PF ratio. So normal is 2 to 3. When you reach 12, you are significantly hypoxemic. When you reach 30, then you are refractory hypoxemia. One thing that regardless of the changes you did on the ventilator, you change the PEEP, you change FiO2. If you calculate your oxygenation index every day, you can follow if your patient is getting better or getting worse. So we said compliance, the higher the better. Here PF ratio, the lower the better. So if your patient oxygenation index, the lower the better. If your patient oxygenation index today is 15, tomorrow is 10, he's getting better. Today 15, tomorrow is 20, he's getting worse. Make sense? So another thing you can follow every day to follow your patient if he's improving or not. Just only you need ABG, and you look at the ventilator screen. You don't have to do anything. Just look at the pressure mean. This is your mean airway pressure that you need to use in the equation. Make sense? So very easy to calculate if you have ABG for your patient. Any questions up till now? Okay, great. This is how to calculate the ideal body weight, that what we talked about for man, 50 kilos for the 5 feet, for women, 45 kilos for the 5 feet, then 2.3 kilos for every inch above the 5 feet will give you the ideal body weight. Here we report the height in centimeters in our hospital. So if you have man, 175 centimeters, take 100 from his height, will be a little bit above his ideal body weight. So it will be 75, his ideal body weight may be 72 or so. So you can use this number. Woman, take 105 from her height. The remaining number will be close to her ideal body weight. Okay, so how about if you have a man 4'10"? So he's less than the 5 feet. For the 2 inches below the 5 feet, you 2 times 2.3, then reduce the 50, so it will be 45. Make sense? Okay, so patient first time in our hospital, you want to intubate him, you think he's ARDS, you want to calculate ideal body weight, and you go and tell the nurse, okay, can you measure his height? And she comes back and tell you, oh, he has bilateral BKA. No family available to tell you the height. Patient is not able to tell you the height. How can you calculate his height? Arm span. Arm span is equal to the height. Make sense? Okay, patient came to the ED, not able to tell you, communicate with you, no family available, first time in your hospital. You ask the nurse, okay, can you tell me what's his height? And she comes back and tell you, oh, he has bilateral BKA and bilateral arm amputation. How do you calculate the height? Sarah is wondering, so very unlucky patients with no arms, no legs, but we had the three situations like that. Anybody is familiar with the Fanconi syndrome? Fanconi syndrome that affects the kidney also can affect the bones. And this patient is, I think, still alive and comes to the hospital infrequently, lives in a nursing home. He has very fractured arms and legs, so really you cannot use that. Another patient with the osteogenesis imperfecta that we had a few times. This patient also has significantly fractured arms and legs. The third, if you have dwarf with normal torso and short arms and legs. So these patients, you use the head to the symphysis pubis times 2. This is how you calculate the height of this patient. Make sense? Great. Any questions? I'm building things over each other. And please, if you have any questions in the middle, let me know. Okay, last slide for ARDS. 6 ml per kg ideal body weight, 100% FiO2. Start with PEEP 8 or 10 for patient with hypoxemia, not just the ARDS. You can go with your respiratory rate up to 35 based on the ARSNet study. So fast rate to compensate for the small tidal volume, 100% FiO2, and PEEP of 8 or 10 as initial start for the VEN setting for ARDS. And I hope you remember from yesterday, the only time in your board exam, you forget 6 ml per kg ideal body weight for patient with ARDS if you forget your name. As long as you remember your name, please remember 6 ml per kg ideal body weight, and we talked how to calculate the ideal body. Any questions about ARDS before I move to the next disease? Looks like no. Okay. So even in non-ARDS patient, there's a meta-analysis in JAMA in 2012. Any patient, not just the ARDS, if you use volume 8 or less per kg ideal body weight, you reduce the lung injury, days on ventilator, even you may reduce the mortality. So really think 100 times if you use more than 8 ml per kg ideal body weight for your patient. There are a few exceptions. We'll talk about one of them. The other exception, if you have a patient that you want to hyperventilate, like patient with impending brain herniation, with cerebral edema, you may need to hyperventilate him for a few hours. After a few hours, the effect will go away until it's a bridge until you do something else. Great. Now we'll move to restrictive lung disease and be ready to send me your answers. 65-year-old woman. Now she is a lady. IPF, admitted to the hospital with acute exacerbation, now setting 80% on high flow oxygen, 100%. She is 5 feet 6 inches, 167 centimeters, and she weighs 100 kilos, intubated by RT, and they are asking for VEN settings. You can start sending me your answers. Okay, I have most of the answers are answering D. So she's 5'6" woman. So what would be her ideal body weight? 5 feet for a woman would be 45 kilos. 6 inches above the 5 feet times 2.3 would be nearly 15. 15 plus 45 would be 60. ARDS is a restrictive lung disease. So any restrictive lung disease, IPF, resection of lobe or resection of lung, all these are restrictive lung diseases. So same settings nearly as the ARDS. 5 to 7 ml per kg ideal body weight, fast rate, high PEEP, 100% FiO2. So 60 kilos ideal body weight times 6 would be 360, respiratory rate 24, and 100% FiO2 and PEEP of 8. Make sense? Great. Okay, so let me clear the responses, and we'll go from there. So restrictive lung disease, 5 to 7 ml per kg ideal body weight, 100% FiO2. You can use the same what they use, the respiratory rate up to 35 to compensate for the small tidal volume, and high PEEP 8 or 10 centimeter water. Okay, asthma and COPD. So patient, 20-year-old man with asthma, admitted with exacerbation, with no improvement in the ABG, 730, 50, 55, 24, on Venturi mask 50%, and intubate. First, let me ask you, what you don't like most in this ABG? Tell me one thing you don't like in this ABG.
CO2.
Hypoxemia, okay? Anything else?
PCO2.
CO2, which one do you
Acidosis,
like more?
respiratory acidosis.
Okay, so the CO2 that's causing the respiratory acidosis. Why you don't like that?
Because it means patient is approaching respiratory muscle weakness.
Wonderful. So most of the asthma during the exacerbation, they are hypoxemic. So this is expected. But usually because they hyperventilate, they wash carbon dioxide. So usually they are hypocarbic or hypocapnic. If they reach normal carbon dioxide, 40, then they are in trouble. They start to tire off. Now you have high carbon dioxide of 50. This patient is pending intubation, so you need to observe him. I usually admit him to the ICU if they have normal or high carbon dioxide. You don't have to intubate them, but at least observe them closely. Make sense? Great. So these are your answers. So start to send me your correct answer. When you are doing that, think, is your asthma patient problem is lung parenchyma or airway? Any thoughts? Is it parenchyma or airway?
Airway.
Airway, inspiration more or expiration more?
Expiration.
Expiration more. Okay, so they have narrowed airway and they are difficult to exhale. So do you need to give them large tidal volume or small tidal volume? Do you need to give them fast rate or slow rate? Based on that, I got, okay, nearly 56% went for B, 33% for A, and 11% for D. Okay, let's think about it. I usually, when I give it in the ICU classroom or on the theater, we have two doors in both of them. And I usually tell you, okay, this room is the lung, the two doors are the airway, and this is the normal airway. If we have one door locked and the other door is open, this is the asthma and COPD exacerbation lung. They have narrowed airway, so one door is locked, one door is open. If our room is in the 4th floor or so, and an earthquake happens, would you prefer us to be 50 people in the room to be able to escape through one door, or 25? Probably smaller numbers, so we can escape through one door. Would you like God to give us longer time or shorter time before the building collapses? Longer time, right? Unless you want to commit suicide or so. So you need longer time, longer expiratory time, and you need smaller tidal volume, 6 to 8 ml per kg ideal body weight tidal volume, and you need longer expiratory time. Normally on the ventilator we have I to E, inspiratory to expiratory time 1 to 2 or 1 to 3. You may need to have it 1 to 4, 1 to 5, make the expiration longer. Think about that. If you have a patient on a respiratory rate of 12, how many seconds for every breath?
1 to 1.
60 over 12, 5 seconds.
Oh yeah.
Yeah, 60 over 12 is 5, I know.
5.
Doctors are not good in math, but anyway. So if you increase the rate from 12 to 20, how many seconds for every cycle, respiratory cycle?
3.
60 over 23, excellent. So you reduce the respiratory cycle from 5 seconds to 3 seconds by increasing the rate from 12 to 20. And all these 2-second reduction is from your expiratory time. Make sense? So this is why think 100 times before you increase your respiratory rate for patients with asthma and COPD. So asthma, COPD, you need small tidal volume. And this is important to know the flow. The higher the flow, the shorter the respiration, the longer expiration. This is what you need for patients with obstructive lung disease. High flow so they can shorten the inspiratory time and prolong the expiratory time. So B is the correct answer, which is nearly 50% sent me the answer for B. Now it's changed to 70%. Okay, good. So we are getting some responses. Okay. Same thing for patient with COPD, the same answer for B. You need small tidal volume, long expiratory time, low rate in the low teen, and you probably may not need very high PEEP for this patient. So for obstructive lung disease, you need small tidal volume, you need low rate, you need high flow. As I said, our ventilators here are on auto flow, but you may need to know that for your board. And then for patients specifically for COPD, keep your oxygen saturation between 90 and 92, not higher than 92. Okay. Okay. you set the patient at 8 ml per kg, and you set the patient at rate of 14, and you put him on high flow, and you put him on oxygen to keep the sat, and you leave. I got the proper setting, and you leave. You don't leave. Because if your patient is very tight, you may have problems. Look at this curve here, this that I have here in green. This is the flow time curve. And expiration is above, expiration is below. You need to be sure that your expiration goes to the 0 before the next breath starts. This is good. But if you see that your patient, when he exhales, he doesn't exhale to 0, and the inspiration starts before he reaches 0, he will retain small volume every breath, small volume every breath. This will create large volume retention, what we call air trapping, and this will increase the pressure, what we call auto-peeping, and you can get hypotension or pneumothorax from that. Make sense? So don't leave, just look at that. If you see your curve like this, right side part, the patient, before he reaches the 0, inspiration starts, you need to do something. He's on 8 ml per kg, I may reduce him to 7 or 6 ml per kg, reduce the tidal volume. He's on the 14 rate, I may need to reduce him to 10, or even some studies say use 8 with obstructive lung disease. Maybe if his I to E time is 1 to 2, make it 1 to 3, make it 1 to 4, prolong the expiratory time so your patient can exhale all the volume that you give. Great. So this is on our Drager ventilator, the older one. We still have few of those. Inspiration, this is the flow time curve. Inspiration, expiration, he is nearly exhaling completely to the 0 before next breath starts. So this patient will be okay. Now you can go to your core room, get some rest. Make sense? Great. Last patient that I will talk about in the settings is DKA. Okay, DKA, the important thing about DKA, we need to know, we talked about the breathing, what you call the breathing, as we talked about yesterday.
Breathing.
Usma.
And
Rapid deep.
Rapid deep, excellent one. So it's rapid deep breathing. So your patient is breathing a liter every breath, breathing 40. So as we said yesterday, never intubate a patient with DKA because his pH is low. Intubate him only if he cannot protect his airway or so. So this your patient, 16-year-old man with the DKA, ABG 70, pH 20, CO2 100, oxygen 6, bicarb on room air, intubated and chest X-rays clear, initial vent settings. Okay, you can start sending the options to see what would you like to use for this patient. Okay, so as we said, DKA, for at least for the initial couple of hours, if you intubate them, and especially if you paralyze them, you need to use large tidal volume. You need to use fast rate to simulate what he's doing. This patient is 100% on room air, so you don't need 100%. You probably need lower, so FiO2 and lower PEEP. You may not need to start with high PEEP. So 12 ml per kg ideal body weight, PEEP of 5, rate of 24, and 50%. Option D is the correct answer. Okay, so DKA, high tidal volume, high respiratory rate, and oxygen saturation based. If your lungs are clear, you may not need to start with high PEEP or high FiO2, and you need to put them on high flow or auto flow. Okay. You can also use pressure support mode and let them pull the volume that they want, simulate, just protect the airway. But in this condition, don't give them any paralytic when you intubated them, and don't give them deep sedation. Okay, I'm done with the vent settings. Anything you would like to ask about vent setting before I go to the troubleshooting?
So I have a question.
Sure.
So after we do the initial settings and hopefully we do the right settings. So how often then we have to follow the patient, especially I think the ABG and
I usually get ABG within 30 minutes to 60 minutes after intubation. So just intubate the patient, confirm your ET tube is in a good position, patient is stable, then just order ABG 30 minutes or 1 hour later, okay? To see how much you need to go down on your sitting or go up in your sitting. Definitely you'll follow oxygen saturation. If your SAT is low, then you may need to do something. Don't wait for the ABG. If your SAT is fine, 90% or higher, then you can wait until you get your ABG before you reduce your setting. If your patient is statin 100%, and after I intubated him, especially if they are COPD, I may reduce the FiO2 gradually to see that they are in the low 90s. Patient is statin in the mid 80s, you may need to increase your FiO2, you increase your PEEP, makes sense. Patient is, the flow is not going back to zero and he has COPD exacerbation, we need to reduce the rate, reduce the tidal volume, prolong the expiratory time. So we need to do some reactions. Once everything looks okay for you, then give it 30 minutes to 60 minutes, then get ABG.
Sounds good.
Wonderful. Thank you. Okay, troubleshooting. I will go with the 4 problems that you may be called about frequently when you are on your ICU rotation as a senior supervisor in July. Hypoxemia is the most common one and the most important one. I'll spend some time with that. Then hypercarbia, hypotension from vent settings, and high airway pressures. Hypoxemia, and I want you to use the word hypoxemia rather than hypoxia. Hypoxemia means low sat and low oxygen in the ABG. Hypoxia means tissue hypoxia, and this can be reflected by high lactic acid in the labs. Makes sense? So hypoxemia is a proper word. Okay, 55-year-old man with bilateral MRSA pneumonia, intubated, vent settings during the day. As usual, our patient in the ICU, they do fine during the day when everybody is available. Then they start to crash when you are on call at night. Okay, so 50% FiO2, PEEP of 5, respiratory rate of 12, 500 tidal volume, and his oxygen saturation is 95%. 1 o'clock in the morning, the nurse called you because now your patient on the same settings, he is satting 80%. What should you think about? Let's turn your mute off and tell me, there are many things you should think about as a differential diagnosis for this, some sort of acute hypoxia. Any thoughts? So I do. Okay. What did you say, Mohammed?
Mucus plug.
Mucus plugs. What else?
Pneumothorax.
Pneumothorax. Excellent. What else?
Pulmonary embolism.
Pulmonary embolism. What else?
Problem with the ventilator, kink
Ventilator
tube.
malfunction. Excellent. What else?
ET tube positions.
Okay, ET tube went above the cord or below to the right main stem. By the way, I wanted to tell you, Dr. Mustafa and Dr. Baweja are saying that you are excellent interactive group. So from yesterday lecture, so I just wanted to let you know that. Okay, what else?
Worsening pneumonia.
Worsening pneumonia. What else?
Hemorrhage, patients fighting, not like synchronizing with the vent.
Okay, asynchrony, ventilator asynchrony, fighting the vent. Wonderful. What else?
ARDS.
ARDS. Well, we are just talking about ARDS. Oh, wonderful. What else? I think you got many of the things. Maybe some, you can develop some acute hemothorax if your patient has lung abscess from MRSA and they invade a vessel or something. Also, you can develop alveolar hemorrhage from any type of pneumonia, more commonly with MRSA pneumonia that cause necrotizing pneumonia. Excellent. What do you need to do? You remember from yesterday?
Yeah, examine the patients.
Yeah, you need to go and examine the patient. Excellent. So this is, you need to think about the causes and the management. We talked about all these causes. So pneumothorax, tube went into the right main stem or above the cord, flash pulmonary edema, pulmonary embolism, mucus plugging, worsened disease, diffuse alveolar hemorrhage, ventilator malfunction, and ARDS. And exactly, you need to go and examine your patient. Usually the nurses, before they call you, what they will do, they will disconnect the patient from ventilator and suction the patient very well and bag him with ambu bag with PEEP. And if the patient doesn't get better, they usually call you. If he gets better, then they will hold on calling you. So this is the experienced nurses and RTs. They know this can happen from some mucus plugging, so they suction and they, to rule out any ventilator malfunction, they disconnect from ventilator. Okay, now we examined the patient. If you want to order stat ABG and stat chest X-ray, that's okay, but don't delay your management waiting for X-ray and the ABG. You examine the patient. You don't have anything to suggest pneumothorax. You don't have anything to suggest ET tube is okay. Also, RT and the nurse will know the tube at the teeth is at what level. So if it was 22 in the morning at the teeth, and now it's 25, it went inside the right main stem. was 22 and now it's 15, maybe it came above the vocal cord. So this is one thing that easily you can assess the tube position by how deep it is at the teeth level. Wonderful. Okay, so we ruled out any correctable etiology. We don't think we have PE. We don't think we have pneumothorax. We AT tube in a good position, no ventilator malfunction. How can we help this patient to get better? You remember, let me go back to the slide to show you the vent settings. So this patient was on 50% FiO2, 5 of PEEP, tidal volume 500, respiratory rate 12. What can you do?
Up either on the oxygen, like the
Oxygen.
FiO2, we can go up, or the PEEP, we can go up to 8 or 10, and then wean him later and call the fellow to like ask for more guidance.
Okay, so you want to go up with the, so Well wants to go up on the FiO2 and the PEEP, which will work faster?
FiO2.
FiO2. So he's on 50%. How you said we go higher on the FiO2? Are you okay with 51%?
No, 100%, and then
Okay,
go down.
so right. So if you tell me go higher and I go from 50 to 51, I went higher, right? So you need to be specific in the ICU. Don't just leave it to the RT to manage. Okay, then I agree. Well, in the acute situation, you need to go to 100%. Make sense? Then wait and see if this will get better. Next step, you need to up the PEEP. Which etiology that we mentioned in the cause, the differential diagnosis of the hypoxemia that will worsen with higher PEEP? Starts with pneumothorax. Pneumothorax, right? Excellent. So pneumothorax will worsen if you use higher PEEP. So if you have undetectable pneumothorax and you use higher PEEP, this can make the pneumothorax worse. Any higher pressure will make the fistula, pulmonary pure fistula, larger. So you can increase the PEEP. I usually recommend that you go gradually with the PEEP at 2 at a time, okay? And until you reach close to the 90% or 88% at least. Make sense? So we will go and examine the patient. We'll rule out any correctable etiology. We will increase the FiO2 from 50% to 100%. Then we'll gradually increase the PEEP by 2 and observe the oxygen. We'll call the fellow, and if you need the fellow to come, what will you tell him? You'll tell him, please come and help me. Don't tell him I have 15 patients coding in the same time, have 25 admissions and all of them are sick. This doesn't mean that I want you to come. If you need him to come, tell him, please come and help me. Okay? This should be clear, and this should be clear to the fellow, because some fellows are better than others coming to help. But if you need the fellow to come, tell him, I need you to come. If you feel the fellow needs to come and he doesn't come, what should you do?
Call the attendant.
Page the staff, okay? Call the staff, okay? So, okay, so what else can we do to help the oxygenation other than ruling out correctable etiology, increasing the oxygen to 100%, gradually increasing the PEEP, and calling the fellow? Do we get oxygen during inspiration or during expiration?
Inspiration.
Inspiration, right? So if you prolong the I time or put an inspiratory pause after the inspiration, you will keep your 100% oxygen more time inside the alveoli. So instead of 1 to 2 or 1 to 3, opposite to the COPD and ARDS and hypoxemia, you need to prolong the I time. Instead of 1 to 2 or 1 to 3, make it 1 to 1, make it 1.5 to 1, make it 2 to 1, prolong the inspiration, or put inspiratory pause after the inspiration to keep the oxygen inside the alveoli for longer time, may diffuse more to the capillaries. Make sense? One thing. Okay, so if you have pneumonia and the right lung is more affected than the left lung, which lung you put down to help the oxygenation? So right lung is sicker.
The right lung put down.
You put that?
Right lung down.
Okay, the sicker lung down. Okay, I'll ask the question again. Which lung you
Good
put
lung
down?
down.
You put the good lung down. Why? Blood flow goes with gravity. Okay, so if you put the good lung down, more blood will go to this good lung, so you improve your VQ matching. Make sense? Ruben, which disease you need to put the sick lung down?
Hemorrhage.
Hemorrhage, bleeding lung. So you have bleeding and you know it's coming from right lung, you need to put the right lung down. How do we die from hemorrhage, alveolar hemorrhage? We die from asphyxiation. The blood will fill the lung, you die. So what you are doing, trying to keep the bleeding lung down, keep the healthy lung away from the blood, so your patient will breathe with the healthy lung. So the only situation you put the bad lung down to improve the hypoxemia if your patient is acutely bleeding from one side. Wonderful. One thing that improves oxygenation and also improves mortality is to put the patient on his face, proning, and we'll talk about the proning, 16 to 20 hours every day. This will improve oxygenation and improves mortality. So we talked about 6 ml per kg, improve the mortality, right? Proning will improve the mortality. Why I didn't tell you remember proning in the board exam and forget proning only if you forget your name? I didn't say that. Why is that? Because proning by itself will not help mortality unless you use it with the 6 ml per kg ideal value. Make sense? That's why your first step is the 6 ml per kg, what you call the protective lung volume protocol. Make sense? So proning and good lung down may help the oxygenation. So we talked about you need to go and assess the patient, rule out any correctable etiology, call the fellow, increase the oxygen to 100% in the acute situation, gradually increase the PEEP, prolong the inspiratory time, and inspiratory pause, good lung down positioning, proning. Okay, what else? If you have your patient on the ventilator, they have 3 types of alveoli, okay, in general. Healthy alveoli, that's why he's still alive. Sick alveoli, full with fluid, that's why he's on ventilator. And all of us will have some alveoli that are collapsed. Can we increase the blood flow to the healthy alveoli to steal blood from the collapsed alveoli and the sick alveoli? Can we give a patient vasodilator that will increase the capillary size going to the healthy alveoli instead of, and does not change the capillary size for the collapsed alveoli and the sick alveoli? Yes, we can. There are 2 medications that we can do that, but the way to do that, if you give it with continuous inhalation. Now they will go to the airway, then they'll find this alveolus is healthy, open, full of air. Then the medicine will go to this alveolus, dilate the capillary going for that. We'll go to the collapsed alveoli, it's collapsed, cannot go there. The sick alveoli that's full of fluid, pus, or blood, or water cannot go there. So their capillaries will not dilate. So it will cause selective dilation of only healthy alveoli. And this can be done by prostacyclin or what you call Flolan, and can be done with another thing is the NO. NO is much more expensive. That's why we don't have it here. If you deal with pediatric, you may have the NO in the pediatric. Wonderful. Another thing that showed improved mortality, if you use it with 6 ml per kg, then newer study didn't show mortality benefit, is paralytic. And the one that was studied is cisatracorium. And the first 48 hours, if you use it, improves oxygenation. And one study in, I think, 2010 improved mortality. 2019 did not improve mortality. And I'll show you the 2 different studies. So paralytic will help oxygenation, questionable improvement in mortality. Make sense? Okay. Your patient is not responding. You are on volume-controlled ventilation. There is another mode of ventilation, what we call APRV. You can switch your patient to the APRV mode. APRV mode means airway pressure release ventilation mode. Is some sort of pressure control mode. And I added some slides this year compared to before, because I had many questions about the APRV, how it works, and how we wean it. So I added a few slides for that. Okay, so this is what we did. We talked about the possible causes, and we went and examined the patient. You get X-ray, stat ABG if you want, but don't delay your care. We increased the FiO2 to 100%. We called the fellow. We increased the PEEP gradually by 2 at a time. Position good lung down if you have difference in the lung infiltrate. Proning will improve the mortality if you use it with 6 ml per kg. Increase the I time. You can put an inspiratory pause to prolong the I time. Inhaled prostacyclin, inhaled nitric oxide, paralytic, and APRV. There were 2 things that we don't prefer to do, but you can do them if really you need what you call recruitment maneuver. You put them on high PEEP, And this is still thing was recommended in the 2020 Society of Critical Care for patients with COVID to do recruitment, but recruitment is two ways: gradually go up on the PEEP or suddenly go up to high PEEP. And they recommended not to go gradually. The stepwise thing, they don't recommend it. Just go to high PEEP, leave them there for 60 seconds. Meta-analysis a few years ago showed that this will not improve mortality and may worsen the mortality. That's why we don't do it. Unless it's a salvage procedure, nothing else is working, you may try to do it. High frequency oscillator, if you will deal with P's, you can use it. If for adults, 2 studies in the same journal, one showed no difference compared to 6 ml per kg ideal body weight and mortality, and the other study showed worsen mortality compared to 6 ml per kg, so we don't use the high frequency oscillator. When I came to the hospital in 2008, I used it multiple times, and the hospital said, okay, we rent it for $1,000 a day, and the ventilator is $14,000. Let's buy one. So we bought one. After that, the 2 studies came that showed no benefit, so we stopped using it. But we still can use it in patients with severe bronchopleural fistula with significant air leak, and trauma patient may have some benefit. Okay, if we don't have that in our hospital, but you will have that in St. Luke's. When you rotate in St. Luke's Hospital, the ECMO. ECMO, if you never heard about ECMO, I'll tell you one word about it. It is dialysis for the kidney. ECMO is for the lung. So you take the blood out of the lung, give it to the machine, will get rid of carbon dioxide, add oxygen, return it to the patient. You still ventilate the patient with very small tidal volume, 3 ml per kg ideal body weight or so, until your patient recovers, then you gradually wean the ECMO. So we can sometimes transfer our patient to St. Luke's or Research Medical Center to get the ECMO if your patient is stable enough to move there, okay? So many things to be done to help your patient oxygenation. Any questions about the hypoxemia? It's the most commonly that you will be called about next year. Any questions?
Yes, Dr. Gohar.
Yes.
Before going up on the PEEP, should we just wait for the chest X-ray to rule out pneumothorax, or just depend mainly on clinical exam and auscultation? And...
I would rely on clinical exam and auscultation. You have ultrasound in the ICU. You will learn on the ultrasound course that will get to you in July or August that you can use ultrasound to look for pneumothorax. So this will be quicker. Also based on your patient stability. Patient is 85-year-old and he is satting 70% versus a patient who is 25-year-old and he's satting 80%. So your patient 25-year-old with 80%, he can tolerate that for a long time. Patient with 85-year-old setting 70% will not tolerate to it. You need to work doing things. Make sense? So then use the ultrasound to look for the pneumothorax as a quick way to look at things. You have the ultrasound and the ICU, and we are buying you another new ultrasound. So we'll have 2 very good ultrasounds in the intensive care. Wonderful. Okay, what's your oxygen goal for patients with ARDS? SAT 88 to 95%, so we are okay with 88%. ABG, oxygen 55 to 80. So if the RT calls you in the morning, your patient yesterday had 60 oxygen on the same setting, but today, this morning, usually they do the ABG 4 o'clock in the morning or so. Now the oxygen is 59. What should you do?
Nothing.
Nothing, because he's at pure goal. Unless he was like 70 yesterday and now he's 59, you may need to do something. Look for what dropped him that significant amount. Make sense? Great. Some goals for oxygen different from that. If your patient is pregnant or sickle, we go for 95. Stroke, acute stroke, we go for 94, minimum 94. COVID patients, 90 to 96. Make sense? There is some data that above 96 can be harmful. Okay, so we may not need to have 100% for every patient. What's a safe FiO2? The one that we can swear about is 21%. Most of the people think 40% or 50% is good. Even some people think 60 is okay. I usually go with 50%. So don't leave your patient on 100% FiO2. You may need to gradually increase the PEEP to be able to lower your FiO2. If your patient is setting 90%, as I told you, if your patient is hypoxemic from the beginning, start with 100% and 8 or 10 of PEEP. And I'll tell you why don't start with 5, Because to lower the 100%, you need to go up on the PEEP. If you go up on the PEEP more than 2, you qualify for what we call ventilator-associated event, and it is reportable. And 80% of our patients with ventilator-associated event were from increasing the PEEP from 5 to 8. That's why any hypoxemic patient starts with 8 to reduce the VAE that's reportable, will make our hospital look bad. And you know from the beginning your patient is setting 80% on 100% non-rebreather. To be able to lower the 100% on the ventilator, you need to start with higher PEEP than the 5. Fluid management. This is something that we usually forget. How much fluid you drink every day?
3 liters.
Maybe 2 to 3 liters maximum. So if you give your patient 5 liters and he's making urine 3 liters, he's doing fine. No, he's not doing fine. He's retaining after the insensible last liter every day. After a week in the ICU, he will be 7 liters higher. And part of that goes to the interstitium of the lung, cause your patient to be more hypoxemic, longer days on ventilator, difficult to wean from ventilator. So study showed that if you use what we call restrictive fluid management, you will reduce the days on ventilator, easier to extubate. Another study in 2006 showed that in the previous 24 hours, before extubation, if your patient is equal or negative compared to positive, they are more likely to pass the trial and more likely to extubate, less likely to re-intubate. So fluid management is very important. Don't be happy that your patient is making 2.5 liters of urine, but you are giving him 5. Is he hypovolemic? That's why I need to give him 5 liters. Is he DKA? Is he pancreatitis? Is he rhabdo? Why I'm giving that much fluid? Your patient is like you, needs 2 to 3 liters on average per day, unless you have intentionally wanted the 5 liters. If you find your eyes 5 liters, think why I'm giving him the 5 liters. This can delay his extubation. Okay, this is a study from 2013, and this is the only study for proning and showed improved mortality if you use it with 6 ml per kg. They proned the patient very early. It's not just proning, it's early proning. So what they found, there is improved mortality on 28 days and 90 days, but only the studies that used the proning with the 6 ml per kg showed improved mortality. Okay, other studies didn't use 6 ml per kg, showed improved oxygenation, but no mortality. When did they prone the patient? Very early. So PF ratio less than 150 on 60% or higher FI2 on people 5 or higher. Very early, but all of the patients that benefited should be on 6 ml per kg at their bed. We prone for 20 hours, minimum 16, so it's between 16 and 20 hours. We have a protocol for the proning here. We like the patient to be on his back when you are here to do echo, to do x-ray, to do things. So we prone from 1 p.m. to 9 a.m., but we keep them on their back from 9 a.m. to 1 p.m. this 4 hours. So you can do echo, you can do chest x-ray, you can examine the patient and things like how does the proning improve oxygenation. Your heart will be down. The more dependent part when you are prone from the lung is smaller and the fluid will shift to this more dependent part. Also, it's more easy to clear the secretion. They will go out. If you have any blood or something can come out. So you simply improve the ventilation, you improve the VQ mismatch, and you reduce your shunting. Contraindications, spine injury, shock, some acute bleeding, so hemorrhagic shock or massive hemoptysis would be contraindication. Pregnancy and recent tracheostomy, I may talk to the surgery for the recent tracheostomy is okay to prone. I may tell the nurses, be careful it doesn't dislodge. Maybe your patient they are very sick and has very recent trach, they may need to suture it well so it wouldn't come out. And also for pregnancy, if you don't have any other options, I may talk to OB, but this is one of the absolute contraindications. When to stop proning? After you put your patient on his back for 4 hours, and you look at your PF ratio and it is 150 or higher, and you are on PEEP of 10 or less, and you are on FI2 60% or less, this is when you say, okay, I will not prone after that. Proning improves mortality if you use it with 6 ml per kg ideal body weight. Neuromuscular blocker, this is a study in 2010 that showed that 28-day showed improved mortality if you use it early. They use the same criteria for the ARDS, the PF less than 150, people 5 or higher, 5 to 60% or higher. 2019 study showed no improvement in the mortality. Okay, but they used a little bit sicker criteria. They used patients on PEEP of 8 or higher rather than 5 or higher. Okay, this is something that came in 2020. A study done in Spain showed that steroid may improve the mortality in ARDS. Just I wanted to put that, and they used the steroid for 10 days, 5 days on 20 milligram, and 5 days on the 20 milligram and 5 days on the 10 milligram, and they used if the patient's PF ratio is less than or equal to 200 on 50% of FiO2 and 10 of PEEP, and this showed improved mortality. Not everybody believed in that, but you know, steroid can be one of the things that you can use for your patient with ARDS based on this study. This is the order set for the prostacyclin, and it's based on ideal body weight. So here is the table. Only fellow can order the proning and order the prostacyclin for your patient. And it is, you start with small dose and gradually go up. The most important is you wean gradually. I had a patient, we started him on 20 nanogram per kg ideal body weight. So this was a 1.8 ml. So it's a syringe, and this syringe is prepared by the pharmacy with the same concentration. What difference in the dose is the rate of the infusion into the ventilatory cycle. And RT is doing that. And I said, okay, patient is doing well. Let's wean him from 20 to 15. ABG next day looks good. Patient setting above 95%. Let's wean him from 15 to 10. Okay, he's doing well. Then let's wean him. Let's stop the prostacyclin. Then we talked to the RT. We need to stop the prostacyclin. Then the RT said he is still on 20. This was our first patient when we started the prostacyclin. Why he's still on 20? We put the order that goes to the pharmacy, but nobody communicated with the RT who controls the rate to reduce the rate. So if you want to wean or increase, you have to communicate with the RT in addition to changing the order with the pharmacy. This is the APRV, and I'll talk a few minutes about APRV. APRV improves oxygenation, and it's a mode type of the pressure controlled mode. And the APRV is abbreviation for airway pressure release ventilation. APRV is not studied to show if mortality benefit. So all the studies showed oxygenation benefit, but there is no study that showed mortality benefit because we did it. There is no one did a study, large study to look for mortality benefit. So we don't know if it improves mortality or not, but definitely will improve oxygenation. So APRV is some double CPAP, so or CPAP with 2 CPAP levels. So it's a pressure control, 2 levels of CPAP. It has a couple of valves. One is we call it CPAP valve, and other one is the pressure release valve. Okay, so this is what we use. So here, let me go back to the curves here. So this high is simply your inspiration, and this low is your expiration, but we don't call them inspiration and expiration because your patient can breathe in and out on the high and in and out on the low. That's why we call them pressure high and time high and pressure low and time low. And these are the things that we need to order for your patient on APRV. Pressure high, time high, and pressure low and time low. Okay, so pressure high is mainly the higher CPAP or the upper CPAP, and pressure low is your lower pressure setting. And usually in these patients, we don't, the pressure low is your PEEP. We don't start with any PEEP, so PEEP will be 0. And I start with 0.5 second pressure low, okay? What pressure that's harmful to the lung above? 30 centimeter water. So I start with the pressure high between 25 and 30. I don't exceed the 30, make sense? So pressure high, to make it easy for you, start with the 30, and pressure low is 0, no PEEP. And time high, I start with 5 seconds, and time low, 0.5 seconds. Now your I to E time is 5 seconds to 0.5 seconds. And instead of 1 to 2, now it's 10 to 1. Your inspiratory time is 10 times. We said longer inspiration will help breathing. Also, if you look at here, your mean airway pressure will be very close to your pressure high because most of the time you are at the pressure high. So as if you are using very high PEEP. Some people use for the pressure high, the plateau pressure. Look at your patient plateau pressure before you switch him to the APRV. His plateau pressure is 25, then you start with pressure high 25. Another way to calculate. For any patient, if you start with 25 to 30, pressure high will be okay. So pressure high 25 to 30 centimeter water, time high 5 seconds, pressure low 0, pressure time low 0.5 second as a start. This will be okay for any of your patient, then you adjust. Make sense? Any questions about APRV? Looks like no. How does it work? APRV works by lung recruitment because you are using high pressure, and most of the time your patient will be on the close to the pressure high. Your main airway pressure will be very close to the pressure high. Then the CPAP is released periodically for a brief period, but we don't want to exhale completely to go to the pressure of 0. This is one of the situations we want the patient to auto-PEEP, and we adjust the time low to auto-PEEP. They have short release along the spontaneous breathing, so they are improving oxygen requirement. They are more easy for the patients, so usually you need less sedation with the APRV compared to other modes of the sedation. So oxygenation will help get better. You may need to reduce the sedation because patient will be. Don't paralyze your patient if they are on APRV if you can, because we want them to do this spontaneous breathing thing. Everybody, if you can do that with me, and this how the APRV looks like. Okay, take a deep breath and stay on this deep breath and pant. Then exhale, inhale again. So don't exhale completely. Then pant, then exhale, inhale again. So we don't allow the patient to exhale completely because we know recruitment of the alveoli and de-recruitment will cause more lung injury. We don't want to inflate the alveoli, then collapse completely. That's why we want this patient to auto-PEEP. So they are more comfortable to the patient, so usually they need less sedation, improve your VQ mismatch, improve your muscle tone, lower your peak airway pressure because you control that, lower intrathoracic pressure, so get better hemodynamic, you may need less pressures. Again, no data showed improved mortality. Which patient you don't like to put them on APRV with very short expiratory time? COPD and asthma exacerbation. They may not do well with APRV mode. So again, we talked about the setting, and you have some here examples for the settings. I'll talk about, this is important thing, this is the inspiratory flow, and this is the only time you need your expiration to start at 50%. So your patient will not exhale completely. So you shorten your time low until your patient starts the breath at 50% or even 75% of your inspiratory flow. So patient will retain volume with every breath and they will auto-PEEP. Okay. If your patient is hypoxemic and if your patient is hypercarbic on the APRV, what should you do? If your patient is hypoxemic, there are 3 things that you can do, or 4 things. Increase FiO2. He's on 50%, increase to 100%, 70%. So you can increase your FiO2 to improve the hypoxemia. Increase your pressure high. Increase your time high. Okay. You can also shorten the time low so they auto-PEEP more. Make sense? If your patient with high CO2, what can you do to lower the CO2? You can decrease the time high. So if you have time high set at 5 seconds or so, then you will have 12 releases per minute. Okay. If you go to 6 seconds, you have 10 releases per minute. So the longer the time high, the less the releases, and in this condition, you will retain more carbon dioxide. If you shorten the 6 seconds to 5 seconds, you have 2 extra releases, so can wash some more carbon dioxide. You can increase the pressure high. If you are below 30, you can go up because the difference between the pressure high and the pressure low is what washes your carbon dioxide and give you the tidal volume during the release. Make sense? If your time low allows you to prolong it, this is the expiratory time, you can do that, but this is not preferred. Rarely you need to increase the carbon dioxide. If your pH is very alkalemic, you may need to do that. Okay. So simply to summarize for the APRV, to improve oxygen, increase FI2, increase pressure high, increase time high. Time high, pressure high, this is your inspiration. You prolong the inspiration, you increase the pressure. To improve the CO2, only if your pH is below 715, this is what we call what to do to correct this CO2. You can correct metabolic acidosis if they have it. Somebody has some lactic acidosis. Don't paralyze the patient so they can ventilate. If they are deeply sedated, lighten the sedation. And then you can reduce the time high if your oxygenation is okay. You can increase the pressure high in the meantime to make the change in the pressure larger to wash carbon dioxide. Do that only if your patient pH is below 715. So if your patient on the APRV is getting less than 4 liters per minute ventilation, think he is oversedated. If your patient is getting more than 12 liters per minute, think he is undersedated and he's agitated. This is what we talked about, the VAE, the definition. If you have patients stable on vent setting for 2 calendar days, not 48 hours, 2 calendar days. And for every calendar day, 1 hour is, if you have PEEP of 5 for 1 hour yesterday, this is the PEEP of the day. If you have PEEP of 5 for 1 hour this morning, this is the PEEP of the day. Make sense? If you increase him from 5 to 8 and stay on 5 to 8 today and tomorrow, this is VAE. 20% increase in FiO2 is VAE. So if you increase the PEEP by 3 or FiO2 by 20%, this is ventilator-associated condition. Why it's important? Because it's, in 2013 in the CDC, they said this definition of ventilator-associated pneumonia should start with that increased oxygen requirement. And they define that by increasing the PEEP by 3 or FiO2 by 20% for 2 calendar days. If you have that, you look for infection-related ventilator-associated condition. You look for any infection, fever, leukocytosis, or if you started the antibiotic and stayed on the antibiotic for 4 more days. Then you have what you call IVAC, infection-related or infection-related ventilator-associated condition. Then after that, if you have IVAC, you look if you have possible ventilator-associated pneumonia, and they have certain criteria for it. So first step for ventilator-associated pneumonia is the ventilator-associated condition, which is increasing the PEEP by 3 and increasing the FiO2 by 20%. Hypercarbia, 50-year-old man with COPD exacerbation intubated, vent setting, tidal volume 7 ml per kg, ideal body weight, respiratory rate of 12, 60% FiO2 and PEEP of 5. This is your ABG, 730, 65, 100, 32. Anybody can tell me what you don't like in this ABG? This patient was
The oxygenation is high. Our goal is 88 to 92%.
Well, doesn't like the oxygenation. Anybody else doesn't like anything?
CO2 is very high too.
Hypercapnia as well.
So
65.
CO2 is 65, okay, and this is causing your pH to be low. Let's talk about the 65 CO2. Would you like, if you think it is high, would you like to reduce it? And what can reduce it? Like, this is my 4 option. So Ruben, you said 65 CO2 is bothering you, this causing the 7.3 pH. What should you do to reduce that?
You can change the tidal volume or respiratory rate.
Okay, so tidal volume higher or lower?
Higher tidal volume,
How about respiratory rate, higher or lower?
higher.
So definitely if you need to reduce the carbon dioxide, you need to increase your minute ventilation. Your minute ventilation is your respiratory rate times your tidal volume in liters, okay? So you will need to, if you want to reduce carbon dioxide, you need to increase the rate or the tidal volume. So let's do that. I'm not saying this is the correct answer yet, but this is very reasonable. You want to wash carbon dioxide, increase the respiratory rate, or wash the carbon, increase the tidal volume. Okay, I increased the rate to 20, 30 minutes later, I got ABG. What happened to the ABG? Ruben, what do you think happened?
The new ABG is the same. So
Why?
nothing.
We nearly doubled the rate from 12 to 20, right? Nothing happened. Before you change the rate of your patient, check if your patient is controlled or assisting. If he's controlled, this change will help your carbon dioxide. You put him on 12, he's breathing 12. If you increase him from 12 to 20, if he's assisting, this patient was breathing 22, and you upped him from 12 to 20 on the vent setting, but he's still breathing 22. So what happened to the patient? Nothing. So before you increase the rate, check your patient. If he's assisting and breathing above the vent settings, then be sure that this is increasing the rate may not happen. Okay, let's see here. We increase the rate and we increase the tidal volume to 10 ml per kg, ideal body weight. Now the patient, 30 minutes later, the RT went to get the ABG, found the patient hypotensive. His art line is showing that blood pressure now is 70/40. What do you think happened from the vent changes that we said? We increase the rate and we increase the tidal volume for a patient with COPD exacerbation. Now he's hypotensive. Do you think about 1, 2 board questions? Number
Tension
1.
pneumothorax.
Yeah, tension pneumothorax. And I like, Ruben, that you said tension, because if you have hypotension with the pneumothorax, you have tension pneumothorax. And how do you treat that? You need it first.
Place second needle in the second intercostal space, and
Then you put a tube. You second intercostal space, right or left?
on the same side of the pneumothorax, which
Yes, it's on the side of pneumothorax that you are suspecting, right? So, okay, so first thing that could have happened and caused hypotension for this patient, he retained volume and developed tension pneumothorax. Okay, what is the other possibility that caused hypotension in this patient without tension pneumothorax? Auto-peeping. He's auto-peeping, increasing the pressure inside the chest, reducing the venous return, reducing the blood pressure. How do you treat auto-peeping with hypotension? Board question.
disconnect him from
Disconnect the ventilator from the AT tube. Excellent. So, and let the patient exhale and empty his lungs. While he's doing that, you'll hear him exhaling for a long time, reduce his volume and rate. Okay, so these are the things to think about, either pneumothorax or auto-peeping, tension pneumothorax or auto-peeping. These are 2 board questions. If I go back to the patient, I will go to what Wael suggested first. I would decrease FiO2. I'm okay with 730 pH for patient with COPD exacerbation. I'm okay with 7.15 pH for patient with ARDS. I'm okay with 7.2 for patient with COPD exacerbation. So I'm okay with that. I don't care about 65 CO2 as long as my pH is 720 and above. But as well said, I don't like 100. And giving him too much oxygen will increase your carbon dioxide, and we'll go through that in a second. So also, if your patient, if I go back, this patient had bicarb of 32. His baseline is around that number. So you really don't need to reduce him more than that. So if you reduce him to 40, the 32 bicarb will go down to 24 in a few days. Then when you try him to extubate him, he will fail the trial or will need to be re-intubated, because he will go to his baseline 65, but he does not have the 32 bicarb to compensate. Then pH will go down at the end of the 30 minutes trial, and you say he failed the trial. He didn't fail the trial. We failed his management. So in this patient, you need to reduce the FiO2, the 60% to lower, to keep his SAT in the 1992 range. Another board question. Very few exceptions. You need to normalize the pH if your patient has cerebral edema with pending herniation, patient has unstable arrhythmia coding with PA arrest, or if your patient has severe pulmonary hypertension because acidemia will cause pulmonary more spasm and worsen your high pulmonary pressure. Remember, if you deal with pregnant ladies, normal CO2 in pregnancy is 28 to 32, not 40. If you're asthma patient in the ED was CO2 of 40 and she's pregnant, she's hypercarbic, okay, because upper normal for pregnancy at 32. Why too much oxygen will increase the carbon dioxide? The most common things that we hear worsen VQ mismatch. So I have this diagram for you. So this alveolus here, this is a bulla with multiple alveoli, as you see, and this is hypoventilated area. Because it's hypoventilated in the normal, it is hypoxemic, and what will happen to capillaries supplying that will vasoconstrict. If you give too much oxygen, we'll raise this bulla that's still hypoventilated, cannot wash carbon dioxide, but this oxygen that you give to the patient will dilate the capillaries that were previously constricted from the hypoxemia. And what will happen? More blood will go to this bulla, and this is some sort of shunting, because they will not be able to get rid of the carbon dioxide. So your VQ match will worsen. The second is what we call Haldane effect. And Haldane described a normal process that happens in the lung and the tissue both Haldane and Bohr, they describe that you have oxygen and carbon dioxide on the red blood cells, and you have oxygen and carbon dioxide dissolved in the plasma. When we measure the ABG, we measure the oxygen and carbon dioxide dissolved in the plasma, not the one on the red blood cells. If you give too much oxygen to the patient, will compete with the carbon dioxide on the red blood cells, release this carbon dioxide from the red blood cells to the plasma. You have worsened carbon dioxide, and this can cause the encephalopathy and all these things. This is what you call the Haldane effect. Too much oxygen will release carbon dioxide from red blood cells to the plasma and cause more hypercarbia. The third mechanism, patients, about 10% of patients with hypercarbia, their chemoreceptors don't feel the high carbon dioxide as abnormal. They only feel the low oxygen. So when you correct the oxygen, they stop hyperventilating. They don't feel the 100 carbon dioxide. So CO2 is 100. Normal chemoreceptors will start to hyperventilate to wash it, but they don't feel the low pH from the high carbon dioxide as abnormal. This is a small percentage of the people. Also, oxygen is an anxiety, reduce the anxiety of your patient. Feel less distressed, and they may fall asleep and breathe slower. So too much oxygen will make them fall asleep. Also, if you replace the nitrogen inside the alveoli completely with oxygen, what will happen? Oxygen is more absorbable, and you have some alveolar atelectasis. These are the 5 mechanisms, but the most important is worsened VQ match and the Haldane effect. These are the most common 2 mechanisms. That's 5. Goal oxygen saturation for patients with chronic CO2 retention is 88 to 92%, not higher than 92%. Okay, let's talk about the last problem that you may be called about, which is increase in the pressures, the peak or the plateau pressure. Okay, so we had these 2 examples yesterday, and I will go for the sake of the time with this curve again. This is our pressure time curve. This is our peak. You get the tidal volume, the pressure go up to peak, then will plateau. Then when the patient exhales, we'll go back to the peak. Okay, I'll give you, I just added some pictures. Forgive me, the pictures are mine. But anyway, so just to remind you, the peak is the top of my head. The plateau is my shoulder. Make sense? Let's see if the shoulder goes up, like if I stand, my shoulder will go up, but my head also will go up. So if I have increase in the plateau with no change and with increase in the peak with the same amount, then this is a problem in the compliance of the lung. Make sense? The opposite is this picture. My shoulder is the same, did not go up, but I pulled my head up. Okay, so now my peak went up and the plateau did not go up, and I have larger difference, more than 10 centimeter water between the peak and plateau. Then this is airway problem. What can cause that? Let's start with the first one. This is my shoulder, this is my head. I will stand. Now my plateau went up and peak went up because my plateau went up. Make sense? What can cause that? Lung problem, pleural problem, abdominal problem, chest wall problem. Lung problem can be ARDS, or the tube went into the right main stem, flash pulmonary edema, alveolar hemorrhage, fibrosis in the lung. All these things will cause increase in the plateau pressure, reduce the compliance. So high plateau means low compliance of the respiratory system. Pleural, pneumothorax. If you have a patient with COPD and his CT shows blebs, and suddenly he gets hypoxemic and his plateau pressure went from 18 to 40, think 100 times in pneumothorax. He developed pneumothorax, ruptured one of the blebs. Make sense? Usually the fluid, the hydrothorax can go up gradually if somebody develops pleural effusion, but somebody coming with trauma, they may develop hemorrhage, so hemothorax, and this can increase the plateau pressure quickly. Somebody's coming with trauma, and X-ray shows minimal effusion, then he gets hypoxemic, plateau pressure goes up, you get X-ray, massive effusion on one side. Think about this is blood, right? This is what can accumulate very quickly. Abdomen. Anytime you start your patient on ventilation, please start stool softener. Even distension from constipation and paralytic ileus. Patient is bedridden. You are giving narcotic, and this will cause ileus. Distension will push on the diaphragm, increase your plateau pressure. Ascites may increase your plateau pressure. Everybody knows how to measure the intra-abdominal pressure to assess for compartment syndrome. What do you measure?
Can you explain that to
Intravesical.
Gohar?
I'm sorry, Ruben, what did you say?
I don't know. Do you mind explaining that to Gohar?
Okay. Who answered?
Intravesicular pressure,
The
bladder
bladder.
pressure.
Makes sense? So Abe as previous nephrologist, so he knows that very well. So you measure the bladder pressure through a Foley catheter. This is something to tell you. And the normal is 12 or less. If you reach 20, this is abdominal compartment syndrome and it's an emergency. Chest wall, somebody said as a reason for the hypoxemia baby patient, it has asynchrony, he's fighting the vent. This can be another thing that can increase the plateau pressure. Also, if you are on high dose of fentanyl or remifentanil, you can get what we call chest wall rigidity. The other side of the screen, if I have increase in the peak pressure, but no change in the plateau pressure, think about airway problem, can be ET tube size very small or mucus plugging in the ET tube, patient is biting the tube is kinked, or airway spasm like asthma exacerbation or COPD exacerbation. Okay. Any question before I go to the last part of the lecture, which is weaning and liberation from the vent? Okay, looks like no questions. Okay, we said the difference between weaning and liberation. Weaning means your patient is on high setting like this patient, and you want to reduce the vent settings to prepare him to get weaned. So you have ARDS patient on PEEP of 18, FiO2 100%, and this is your ABG 735, 45, oxygen is 85 and 24 bicarb. Does your oxygen allow you to wean the vent settings? Yes, because we said our goal is 55 to 80 in the ABG. He is 85, so we have some room to wean the settings. Weaning the pressure first, weaning the FiO2 first, controversial. No data showed one is better than the other. There are a few situations. I wean the pressure first, but usually what I do, I start weaning the FiO2 by 5 to 10% based on my oxygen saturation and ABG. And I go down by, if my patient is setting 98%, I may be able to go down by 10%, wait for 1 or 2 hours, reduce another 10% if he's above 95. If he drops below 95, then I hold on reducing the FiO2, wait for some time. Effect of reduction of FiO2 will show quickly, but the reduction of the PEEP will take some time. That's why I usually go down to 50% and wait. I don't reduce him to 30%, even if he's setting okay. I stop at 50%, I start weaning the PEEP by 2 at a time, wait for 6 hours, because the effect of weaning the PEEP is the recruitment and may not show immediately, may take some time to show up. So you wean the PEEP by 2 at a time, wait for 6 hours, I can reduce another 2. I usually don't reduce more than 4 or 5 a day. So your patient is 18, I may go to 16, wait for 6 hours, go to 14, and wait till tomorrow. Because if you go down quickly, what will happen? You will de-recruit, and to recruit again, you may need higher PEEP than the 18. This is one of the situations in the ICU when slower is faster, okay? Slower weaning of the PEEP is faster to extubate the patient because you guarantee he will not de-recruit, he's going in the proper way. COVID patients, my experience with the COVID patient, even reducing the PEEP by 2, they may get significantly more hypoxemic. So be careful, specifically with COVID patients, weaning the FiO2 and weaning the PEEP, you should be a little bit slower than other patients. So I start weaning the FiO2 until I reach 50%, 10% at a time. If SAT specifically more than 90%, you don't have to get any EVGs, just follow your SAT. Also, once I reach 50%, I reduce 2 at a time and the PEEP, wait 6 hours, reduce another 2, then wait till tomorrow. Then in the morning, so he's doing well, I reduce another 2, wait till the afternoon, reduce another 2. Liberation for the vent. So to take your patient off the ventilator, you need to assess 3 steps. Is he ready? And by ready, we mean your patient is, what caused him to be on ventilator is improving. If he is intubated for hypoxemia, is getting better. Intubated for altered mental status is getting better. Intubated for high carbon dioxide is getting better. So what put him on the ventilator is getting better. Then he is ready. He's not requiring too much FiO2 and not too much PEEP. Then you assess, is he able to come off the ventilator? He doesn't need the ventilator, and you do the breathing trial, spontaneous breathing trial, to assess if he can come off the ventilator. Then you assess, does he need the ET tube? Can you give me an example for patient does not need the ventilator but still needs the ET tube?
One with tracheal damage.
Okay, what did you say, Ruben? Can you repeat that, please?
Someone with tracheal damage.
Tracheal damage, so any upper airway problem, so angioedema, tracheal injury, laryngeal mass, so this patient will need the ET tube. Another example, if your patient is completely altered, he is post-cardiac arrest, he's not waking up, but he still have brain stem reflexes, and family wanted to continue. This patient is not awake to protect airway. Or your patient is very weak and he has copious secretion. And if you take it out, he may not be able to clear the secretion. In this condition, you may need to think, should I do early tracheostomy for this patient to be able to come off the ET tube? Great. So this is a question that we talked about yesterday. So do you, what's the most cost-effective thing to prevent VAP? Why do we need to extubate the patient as early as possible? Because your patient every day on the ventilator will put him at risk of ventilator-associated pneumonia, and this will increase his days on the ventilator, days in the ICU, and also hospital mortality. So the most cost-effective that will cause $0 is head of bed elevation 30 to 45 degrees. So any patient on ventilator, please be sure he is 30 to 45 degrees, okay? Subglottic suction, continuous or intermittent, will help. Why is that? Ventilator-associated pneumonia comes from secretion around the air pharynx and from the oropharynx. This is, you have your ET tube here and your cuff is inflated. The cuff, we don't inflate it very much because if you inflate it too much, will cause injury to the capillaries in the trachea and you get granulomas and stenosis in the trachea after extubation. So we inflate it enough to avoid the escape of the air. Usually we keep it on less than the capillary pressure. Capillary pressure at 30 millimeter mercury. So we keep the pressure on the cuff at 25 centimeter water or less. So we don't inflate it much. So really your secretion accumulates above the cuff and can go trickle around the cuff to the lung and cause the ventilator-associated pneumonia. So some smart person said, okay, I will have a tube connected to the ET tube and ends above the cuff and connect this tube to continuous suction. So here you connect it to suction, continuously or intermittently. So any secretion accumulates above the cuff will be suctioned out. So it wouldn't trickle to cause the pneumonia. D worsens the VAP. The frequent change in the circuit or interruption of the circuits will increase your ventilator-associated pneumonia. Again, by already, the etiology that caused it has improved. Also, patient on 40% or less, some places are okay to trial with 50%. People 5, some places like to trial on 7, not on multiple pressors. Awake can protect his airway, has good cough, good gag, then your patient is ready to trial him. Trial, usually we do pressure support trial, 5/5. What does it mean? Pressure support of 5 above the PEEP of 5. So during inspiration, you will get 10 centimeter water. During expiration, you will get 5. 30 minutes versus 120 minutes, well studies, equal outcomes, so we do 30 minutes. When to do 120 minutes, very few patients that we need to do 120 minutes, and this is based on expert opinion. So randomized controlled studies is the strongest evidence. Expert opinion is the weakest evidence. So who should we trial them for longer time, for 2 hours? They think maybe if your patient is on ventilator for 10 to 15 days, his muscles are weak, develop some weakness of the muscles, and you may need to trial him better, longer time. This is expert opinion, not based on studies. I like to trial patients with myasthenia gravis for 2 hours. And this is based on my experience with one of my our patient that every time she passed the trial at 30 minutes, she intubated during the night. Why is that? She can, with myasthenia, the more you work the muscles, the more weaker they get. Every time we trialed her for 2 hours and she passed and extubated, she did not need to be reintubated. Make sense? So what are the predictors after you do the trial? By the way, not every patient needs to be trialed. Not every patient needs ABG after the trial. I have some young person, 25-year-old, who came last night For alcohol overdose, was altered, intubated because of altered mental status, and now he's fully awake. His X-ray looks good, and he is very irritable when he woke up because his tube is bothering him, and he's trying to pull the tube. I may just extubate him. You don't need to trial him. His lungs are clear. He did not aspirate when he was altered. He's setting 100% on 30% FI2 P45. He's very strong, young person. Just extubate him. Okay. So somebody, you trialed him for 30 minutes, ABG, RT is busy with other patient, and you need ABG. He has healthy lung, and he's setting 100% on 30%. He's pulling a liter tidal volume with every breath, and he's breathing 20. ABG will be fine. So why should I get ABG? He's very irritated and trying to pull the tube. By the way, most of our self-extubation happen at the end of the trials. So if you don't observe the patient, a patient is strong, even with the restraints, they can get to the tube and get to the handout. Make sense? So patient is ready. If your RSBI, and we'll talk about the RSBI, is less than 105, which is the respiratory rate over your tidal volume in liters. Also, your patient minute ventilation is reasonable, not very high, not very low. If you get ABG, ABG is reasonable. Patient is awake, can protect his airway, can clear his secretions if we have secretion. This is study. The respiratory rate and the RSBI are the most predictive for possibility of extubation, but not the only parameters. You need to look at everything. If the patient fails the trial, you need to tell me why he failed. So if you tell me patient failed the trial yesterday, and you need to tell me, did he fail because he was hypoxemic? Then he's not ready yet. Did he fail because of fast rate? Then the fast rate, was he pulling 200 tidal volume with the fast rate of 40, or he was breathing 40 and he was pulling 800? This patient who was pulling 800 with the 40 rate, he doesn't like the tube in his throat. It's bothering him. But the patient who is pulling 200 and breathing 40, he's weak. Make sense? Different. Hypertensive. Is he agitated or irritated during the trial? And you may need to trial him on small dose of sedation or consider Presidex. Okay? So this is important to know the reason for the failure so you can manage the reason so your patient can pass your trial. Okay, these are situations that we talked about, people who may need to ET tube, and you may need to think earlier about the tracheostomy. Chance to get re-intubated is 12 to 14%. So one of every 6 patients you extubate, you may need to be intubated. I usually, if my patient is intubated for respiratory or heart problems, I keep them after extubation for at least a day in the ICU, because the chance one of the 6 I extubated within the next 48 hours will need to be re-intubated. If you have a reasonable family and you explain to them, okay, your father passed the trial, we'll extubate him. He is ready to come off the ventilator, but there is a chance 14% that he may need to be back on ventilator. Then their father at midnight needs to be re-intubated, and you call them to update them anyway. Any event, major event happen in the ICU, like patient comes to you from the floor to the ICU, patient gets intubated in the ICU, patient had major event that you need to start dialysis, you need to update the family and document that. So family will not give you a hard time. Oh, was he extubated early? That's why he needed to be intubated. They know the national statistics is 14% need to be re-intubated, okay? Even if you do everything correct, they may need to be intubated. Once you extubate your patient, you need to go and examine the patient, listen for his neck by your stethoscope, be sure he's not stridors. If he has stridor, if it is mild, your patient is breathing 20, satting 94%, 95% on a couple of liters, then your patient can be managed for this stridor. You can hear the stridor with your ears or with your stethoscope, but he's comfortable, satting well. You can use one of these things. If it is severe, don't wait. Call anesthesia to intubate him, because he will be difficult intubation. Somebody is hypoxemic or in severe distress, stridorous, and he's hypoxemic in severe distress, call anesthesia immediately to intubate him, then start steroid to help the edema. If he is mild, you can use the racemic epi nebulized, not IV or sub-Q, because somebody a few years ago ordered it IV, and the pharmacy picked it up and came to us, oh, do you really need racemic epi IV? No, said it is nebulized. And you give it with albuterol, 1 amp of the racemic epi with albuterol nebulized. Or you can use what we call heliox. Then you add the steroid. Heliox is a mix of helium and oxygen. Everybody saw the heliox, the helium in the hospital? No? Where do you see the helium commonly in the hospital? Give you a hint, and the gift shop. You see these balloons, get well soon and things like that. If you leave this balloon from your hand, it will go to the ceiling because it's full of helium. And helium is less dense gas than the nitrogen. So helium goes in what we call laminar flow. So if you have narrowed upper airway, it can pass through this narrowed airway and carry the oxygen with it. What we have here in the hospital, 70-30, 70% helium, 30% oxygen. You can have 80-20, okay? You can have 60-40, but not less than 60% helium. It will not work. The nitrogen goes in a turbulent flow. So when you say 40% oxygen, this is 40% oxygen and 60% nitrogen, okay? So nitrogen cannot pass easily through the narrowed upper airway. Okay, APRV has specific weaning, and this is a little bit much for you, but I will be happy to listen, or if you have any questions to answer so we can finish in time. But I had some slides for the APRV. While you are answering me, I'll go through the slides to record. So simply you are trying to switch the APRV to a CPAP mode, okay? So we can extubate him. You wean FiO2 until you reach 50. You wean the pressure high until you reach 18. Then you say, I'm ready to do the spontaneous breathing trial. Okay, any questions? And I will scroll through the slides when you are doing the questions so you can read them if you are interested to see how APRV mode. Usually I teach that for the fellows more than for residents. But I'm ready for any questions if you have, and I'll scroll through the slides for the APRV. Any questions? So this slide, we are trying to switch to CPAP. You see the lower part. This is how we reach the FiO2 less than 50% or less, and the pressure high went down until we reach 18 centimeter watt. This is how you assess the readiness. Also, it will differ if your patient can be extubated to BiPAP, like what we talked about yesterday, or he cannot extubate to BiPAP. The weaning trial would be different. This is one of the situations we do 2 hours weaning trial. Okay, I will not talk about the ERVO, but this is something that usually I have it to discuss. We use ERVO a lot for patients with COVID. Any questions? Looks like no.
Dr. Gohar, I have one question.
Sure.
So when we do racemic epinephrine for Strider,
okay,
the last time there was a patient that I was taking care of and there was a confusion. Do we do it as needed basis, like once in a while, or do we do it scheduled or continuous?
No, it's not scheduled. It's as needed. Usually, I hope they will respond to the one dose that you give, and then things will get better.
Okay. And is racemic epinephrine something that we can do, like if it's something that we can nebulize through with albuterol, can we do it on the floors, or?
Yes,
of course,
you can do. Just you need to call the RT. You need to order it and call the RT to do it. But if you think your patient has Strider and need racemic epi, he may need higher level than the floor unless you observe him closely and he gets better.
Thank you.
Okay, I don't know if Dr. YD joined us. Okay, we can get 1 minute until Dr. YD joins. Okay, looks like Dr. Waidi joined us. They are in a small break, so they should be back soon. Dr. Waidi, would you like to share your screen with us?
Okay. Okay, am I on?
You are on. Just, I don't see
I
the
can't
screen
hear
yet.
you. There we go. Okay, let me, it wouldn't let me,
It should be a green thing on the bottom.
yep,
Just click that and pick your, double click your screen, your presentation. Will we see it now? Okay, thank you very much, Dr. Waidi, for this great lecture. We will have hour and a half. Dr. Waidi, he will talk about cases with endocrine emergencies that you will face during your calls as a senior for the intensive care. And Dr. Waidi is giving this lecture since we started 9 years ago. And thank you very much, Dr. Waidi, for your great teaching.
wow, has it really been that long?
That long, this is the ninth course. So the
Wow.
ninth healthcare course. Yeah.
I think maybe Dorota gave a few of them through the years too. I'm
Probably,
not
yeah,
sure.
maybe the
Yeah,
first one or two.
yeah, very good. Well, maybe next year we get to do this in person again. That would be nice. I miss the interactions, to tell you the truth.
Yeah, this group is very interactive. So if you have any discussions, they will participate. We had very good comments from the lecturer yesterday about their great interaction. So I hope we will have the same feeling today.
Oh, excellent, excellent.
Wonderful. I think we are ready to start.
Yep, I don't know why I have to use the arrows down here. Okay, so we're gonna go through some cases. So it's like people you're gonna see. A 24-year-old gentleman with type 1 diabetes comes to the ED with flu-like symptoms for about 3 days. Complains of polyuria, polydipsia, nausea, abdominal pain. Sort of typical, you probably have an idea what's going to happen already. Lost 5 pounds in spite of drinking water and orange juice. His home regimen is Lantus 30 units at bedtime and Humalog 10 with meals, which he has not taken because he's been ill and he hasn't been eating, so he hasn't taken his insulin. On exam, he's tired, dry mucous membranes, temperature's 101, heart rate's 110, respiratory rate 26, blood pressure 110/70. And on lab, his UA shows glucose and acetone, so ketones. His glucose is 380, so not terribly high. Sodium 140, potassium 5.5, bicarb 5, and creatinine is elevated at 2.2, and pH is 7, PCO2 10. So we're going to talk about diagnosis, initial treatment, insulin doses, and sodium, potassium, phosphorus, and bicarb issues. So as you can imagine, he's got DKA. It's interesting that the hyperglycemia can be mild. Even more so now, we have a lot of patients who will do exactly what this person did. They won't take their insulin because they're not eating, and their sugars get higher and they're feeling miserable, and they decide they're going to go to the hospital, and they take a shot of Humalog, and then they leave for the hospital. And so at home, their sugar was, 600. And by the time they get to the hospital, it might only be 400 or 380 or something. So, it's not enough that they've done anything for their acidosis, but they've made the glucose look better than it really was. And so you might sometimes wonder why isn't their sugar higher? Ketones should be present, and they have an anion gap metabolic acidosis. So what does it require? It requires either an absolute or relative insulin deficiency. And that's sort of why patients with type 2 diabetes can occasionally get DKA. Often it's a new diagnosis of type 1. Unfortunately, especially in our population, it's often due to non-adherence of insulin. And you'll see patients that are frequent flyers and they come in and they actually usually correct very fast because the issue is they didn't take their insulin. The patients who have it for another reason, such as an illness, they may take longer to correct because they have a more serious underlying cause, I guess, is the way I'd put it. And that can be any trauma, any stroke, MI, infection, surgery, any major stress that can push somebody over the edge. I had a young guy, and he was in a motorcycle accident and broke his jaw, and overnight went into DKA. And so just from the non-healing fracture of his jaw. Pancreas damage. And so sometimes we'll see that with people who develop severe pancreatitis. There are drugs that can do it. Most of these are not big offenders, but obviously steroids and thiazides. Now the thiazides, I'm gonna make a comment because it was much more common when I was training than you'll see it. And that's because of a difference in doses. So we still use a lot of hydrochlorothiazide for blood pressure, but we often start at 12.5 milligrams. And when I was an intern, our starting dose was 50 milligrams of hydrochlorothiazide. And in patients like that, I remember I had a little lady about 60 years old, no history of diabetes. I put her on the 50 of hydrochlorothiazide on a Monday, and Thursday she was in the hospital with glucoses over 600. So it's just something to remember that it can do that, usually at the higher doses. We still use those higher doses, usually not for blood pressure. The higher doses are more used for people with stones to try and reduce the calcium in the urine. Steroids are another thing that people respond to differently. We give out steroids a lot. And, you know, face it, it's a double-edged sword because steroids can save lives. But some people, especially with diabetes, can be very sensitive to the steroids. And we say, well, it'll raise your sugar a little bit. I've seen people go over 600 with, you know, a 50 milligram dose of steroids. So just keep in mind that it can be worse in some patients than others. Cocaine is another thing that can push people over into DKA. Probably other drugs too. It's just cocaine seems to be more common. There is a mortality rate still of 5 to 10%. We think, you know, DKA is not a big deal, but usually the mortality comes from the underlying condition rather than the DKA itself. So it's important to figure that out. So some patients with type 2 diabetes, particularly who've had it a while, have had their insulin decrease over the years. And so under situations of stress, you require more insulin. And if you don't have more to give, that's when you run into it. Obviously, type 1s, it's straightforward. They just can't make any. So if they aren't taking extra or they don't take their regular doses, they run into that. And so that's it. Glucagon excess is not really, I think, that important. There are additional hormones that are involved, catecholamines, cortisol, growth hormone. It's not that we do much about those, but they, under conditions of stress, these are all stimulated, right? And all these things can raise your sugars. So they're adding to your risk. And if you think of it, the real issue is not high sugars. The real issue is the glucose can't get into the cell. Okay. Think of the insulin as the lock that opens the door for the glucose to get into the cell. And so you're starving. Particularly the brain is starving. And so the brain wants something. And so glucose gets utilized in muscles, peripheral tissue, and it can't be used. And so it causes an osmotic diuresis. And the higher the glucose, the more volume you lost. And gluconeogenesis kicks in because the body says, I need glucose. The brain says, I need glucose. And the brain is very dependent on glucose. Other tissues can get away with some other things, but the brain primarily needs glucose and says, you know, if you don't feed me, I'm going to die. And if I die, the rest of you is worthless. And so the liver says, fine, I'm going to make some glucose. So gluconeogenesis kicks in. The problem is, of course, we still don't have the insulin to open the door. And so the brain continues to say, I need glucose, I need glucose. And they can't get where it is. Finally, the liver says, well, you know, I've been making you glucose and you're not using it. So I quit. I'm not going to make glucose anymore. And gluconeogenesis shuts down. And then the brain, of course, keeps complaining. And what happens, I mean, what I'm giving you is a way to remember, not obviously the physiologic way that things happen. The liver says, well, I made you glucose already and you didn't use it, so I'm not going to make any more, but you can have some ketones instead. And the brain says, well, I don't really like ketones, but it'll keep me alive for a while. And so it uses the free fatty acids to increase the substrate for ketones and to try and keep the brain alive. It's inefficient, but it's a survival mechanism that you're forced into. One of the things to keep in mind is there are different ketones and they are in equilibrium, but we usually can't measure all of them. And so our job in treating DKA is to eliminate the ketones. Okay. And since we can't measure all of those ketones, you'd say, well, how do we know when we've done that? And the answer is the anion gap closes. Presentation, you'll see this a lot. So polyuria, nocturia, thirst, some weight loss, 20%, blurred vision, very common. The higher the sugar, the more blurred vision. 20% to have some weakness. Abdominal pain, nausea, vomiting in 70%. Very, very common. Also, elevated white count, very common. Depending on how high the glucose gets, you can have confusion, mental status changes, and ultimately coma. When things get bad, you get Kussmaul respirations. There's tachycardia, hypotension, hypothermia. Again, this is usually a bad sign when you get there. But common things, abdominal pain, nausea, and vomiting, which is important because you have to make a distinction whether this is from the DKA or whether there's an underlying problem such as a ruptured appendix. One will go away taking care of the DKA, the other is the cause of the DKA. So it takes some determination to figure out what's true. So what are we going to do? The BMP is obviously the most important thing. You want to know the glucoses, the anion gap, CO2. Some people measure phos and magnesium. Some people don't measure it all the time. First time through, I probably would measure it to see where you're starting. A lot of people will replace, some people will say it'll correct on its own eventually. A blood gas is not required to make a diagnosis. Nobody will fault you for the first one, but unlike, again, 35 plus years ago, we did blood gases every hour, and you ought not to be doing that. One blood gas is okay. More than that is rarely needed. Depending on what you think the cause is, amylase and lipase can be useful if there's pancreatitis. Lipids can be important, pancreatitis. We've had patients come in with very high triglycerides causing their pancreatitis. I think, well, I actually don't know the highest I've seen because they stopped measuring at 20,000. So, and that really destroyed the entire pancreas. That was a patient without a known history of diabetes who obviously developed diabetes, and it was permanent because it destroyed the pancreas purely from the triglycerides. CBC, remember, white count can be present in DKA just from the DKA. And, but, you know, if it's 40,000, it's probably not simple DKA. 12,000, maybe so. I would measure ketones. I don't care where you measure them from. You can get serum ketones, you can get urine ketones. They're both valid. Remember, though, that if you don't eat, we'll all get trace ketones. And so trace ketones are not really what we're looking for. We're looking for moderate to large ketones. It's worthwhile to get an EKG. Potassiums can be any place, and we'll talk about those a little bit. And, you know, again, depending on what you think causes it, you might want blood cultures, you might want a chest x-ray. Those things aren't automatics. You know, if somebody just forgot their insulin and they look good otherwise, I probably wouldn't do any of those things. I'd still monitor them because of for rhythm because of the potassium issues that occur. They are volume depleted. And most people in DKA are 3 to 6 liters down. The critical care guys have formulas for water depletion. You know, in DKA, we generally don't do those because most of these people are younger and healthier, and you can dump the first liter in as fast as you want and then slow it down and get them so that you've got a couple liters in as fast as possible. When the glucose comes down, you want to make sure that you don't back off on the insulin that you're giving. Okay, and we're going to talk about that in a bit. So when the glucose gets around 250 to 200, you add D5 or D5 half normal or something to maintain the glucose so that you can maintain the IV insulin, because that's what drives the ketones out. Okay. And so insulin's the key point of the treatment, insulin and fluids. It suppresses gluconeogenesis and lipolysis and ketogenesis. We use Humalog in our drips here. It's fine. A lot of hospitals will use regular because it's cheaper. They will act exactly the same given IV. Some people give a bolus, and you'll see all kinds of things. It can be 0.1 to 0.15 unit per kilogram IV bolus. Some people just give a 10 unit IV bolus. I really don't care. I don't think it's a critical component. There's nothing wrong with it. The important thing is that to get the infusion going as fast as you can, and we have a DKA protocol. And as long as they have done the right things, that'll work okay. One of the things that sometimes can happen, so insulin can stick to the tubing. And so when you have an IV infusion, the nurses are supposed to run about 50 cc's of the insulin through the tubing, just down the drain. And that's to coat the tubing. If they don't do that, then if you give a bolus or they're running it, it's going to stick to the tubing and going to delay the insulin getting there. You want the sugar to drop 50 to 70 milligrams per deciliter per hour. Rarely does DKA get above 900 for glucose, but I've seen 1200. So, I mean, it can be. Again, I told you when you get down around 200 to 250, change the IV fluid so you've got D5 so you can drive out the ketones. It also helps prevent the cerebral edema. When do you stop the IV insulin? When your gap closes. So our gap runs a little higher here than some hospitals, but certainly when you get below 12, the glucose doesn't have to be less than 200. You may be artificially holding that glucose up, but once the gap closes, you don't need to be giving tons of extra glucose because you're going to be backing off on the insulin. Some people wait for the bicarb to normalize. I don't think you have to have it normal. I think over 15 is probably safe as long as your gap is closed. The CO2 just takes longer to come up, and it will continue to rise as long as you're doing it. Bicarb should rarely be used. The guidelines suggest if your pH is less than 6.9, you can give bicarb. There's some data that suggests that bicarb increases the risk of cerebral edema and herniation. Remember, there's a pseudo hyponatremia. And so you can adjust, and people use different numbers. So some people say for it's 100 for every 100. It's 1.6 for every 100. Some people say over 150. Some people say over 200. That's not much of a difference. So it's not going to make a major difference in your calculation. So if your sugar's 1200, then you take your sodium and add 16 to it. So if their sodium's 120 for the 1200 glucose, their corrected sodium would be 136, pretty close to normal. And I just use that for round numbers, using things that are easy for you to see. Does everybody understand that calculation, or did I make you more confused?
That's clear. Thank you.
We understand.
Okay, very good, because that's an important thing. Because, you know, let's say you had a sugar of or a sodium of 140 with that same glucose of 1200. Then you have a problem. That's actually an elevated sodium and something else is going on. Maybe the issue that puts you in there. So always do the correction. And with hyperosmolar, you'll really see some low sodiums that just look like, oh my God, they have to be. I mean, I've seen down like 110. Potassium drives people nuts. the real key is to replace it early. So if your potassium is less than 5, go ahead and start. What we know is everybody in DKA is whole body potassium depleted. Urine losses, GI losses, whatever. If you wait until the potassium is low, you are gonna be behind. Insulin drives potassium into the cells, and that's gonna lower it further even if you come in high. The other thing that's important is to know where you are. So everybody needs potassium. I mentioned the guy with the broken jaw in the motorcycle accident. He was a very interesting case because his sugar was 1,010. And I remember because his potassium was also 10. And believe it or not, he still needs potassium. Now, you're not going to give it when his serum potassium is 10, because that's a bad thing and you can kill the man, which is always poor form. But once you start giving him insulin, it drives that potassium into the cell, and you know he is whole body potassium depleted. So even though he comes in with a potassium of 10, he needs potassium, and you start it when you get to when you hit 5 or below. Okay, otherwise you'll be behind. Now, some people will come in and their potassium is very low. Remember, if you give insulin, it's going to go lower. So the rule is if the potassium is less than 3.5, replace the potassium first before giving insulin so that you don't get an extremely low potassium. I've seen potassiums very commonly in DKA in the 2s. And we like for that not to happen. So keep those things in mind. They're very critical. Believe it or not, they're all in the DKA protocol, but you know, you have to actually have people follow the protocol correctly for it to work correctly. And as if you ignore those things and you just start the insulin without checking a potassium, you'll be in trouble. And when you're behind, the supplement potassium in the protocol is not going to get you to normal when you're 2.5. You're too far behind already. So try not to get behind on your potassium replacement. Phos correction, you know, certainly most people would say if it's less than 1, you ought to replace it. Some people use a higher level. I'm not sure the data for DKA shows that there's much benefit, you know, if it's 1.5 to replace it to get to 2. It can be worsened with the insulin treatment. So some people follow it. Most people actually don't. And there's always a risk with phos, and it's not pleasant to replace. Oral phos causes diarrhea, and IV phos can really burn. Of course, if your patient's out cold, they won't complain. Remember supportive treatment. So do your ABCs. Airway is important. Obviously, when the kid with the motorcycle came in, he was comatose, and very interesting because his jaw was wired shut and we still had to intubate him. Fortunately, we had an ENT present who visualized his vocal cords down one nostril and intubated down the other nostril very quickly to protect his airway. Usually it won't be that bad because most of our DKAs do not have their jaws wired shut. But this guy, this example I'm giving you, I mean, I remember because it was very difficult for the whole thing. You want to measure BMPs. helps you with your anion gap, your potassium level, and your CO2. In the Cerner labs, if you scroll down, there will be a diabetes inpatient view. And if you use that view for somebody with DKA, all those things will be right in front of you. You'll have your potassium, your gap, your CO2, the blood gas will be on there. So you'll be able, ketones, I believe, are on that view as well. So it's a very good view for following somebody in patient for DKA or hyperosmolar syndrome. And as you get more stable, you can do that. Remember, even though you're doing this, you're going to be doing finger stick glucoses every hour to follow the glucose levels. And remember to try and think of what caused this. Sometimes it's obvious, sometimes it's not. Complication, the glucose level itself, potassium, cerebral edema with fluid shifts, more common in kids. Altered mental status is you're going to see. Severe headache, can cause seizures, the pupils dilate, bradycardia, respiratory arrest. This happens, the mortality rate is extremely high, 20 to 40%. Pulmonary edema can occur. Now, I went through all this stuff, and those of you who have taken care of DKA know that these are rare things. Most of the time, people correct very well, and the protocol works very well. So this patient we went through got treated with 500 cc's of normal saline for 4 hours. Potassium's 4.2. He got 10 units of regular IV, followed by 7 units per hour on the drip. In 24 hours, he's no longer nauseated, he's hungry, has good output. Blood pressure is 120/80, heart rate's down to 80, respiratory rate's 14, glucose is 210, bicarbs up to 19, sodium looks good. So the question is, what do you do? And I really like you guys to do it an ideal way. I'll tell you the ideal way, and then I'll tell you an acceptable way. and then what I beg you not to do is don't write the order that says stop DKA protocol, start insulin, Lantus, whatever, 20 units at bedtime, and Humalog, 8 units with meals. Please do not do that, because what happens in that case is the nurse goes over and turns off the IV insulin. And then they wait for the Lantus and Humalog to come up from the pharmacy. And the half-life of IV insulin is 6 minutes. So in 30 minutes, they're out of insulin. The gap goes up again. The glucoses start going up. And you say, well, it's retractable, recurrent DKA. No, you messed it up. And you allowed that patient to go back into DKA when you had corrected it all. And the way to avoid that, the perfect way would be to go to the titratable insulin drip, which adjusts based on the blood sugar. And in a perfect world, you'd turn off the D5 and you'd let them stay on that, whether they ate or didn't eat, for 24 hours. And that would give you calculations for the insulin doses. Now, the reality is we don't let our patients stay on an insulin drip for 24 hours just to do calculations. So I would still switch to the titratable drip. And then you have to give insulin. So you want to make sure they get long acting and short acting. So if you are just starting and they haven't gotten any long acting, you need to overlap the IV by at least 4 hours from your Lantus. Okay, 4 hours. For short acting, you need to overlap by 1 to 2 hours. Now, one of the ways to make life easier and prevent some of this stuff is if you have a known diabetic and you know their Lantus dose, you can continue that even while they're on the DKA protocol. And the same holds true for the titratable drip. And that way they already have the long-acting insulin on board. And then you can just give them their first dose of short-acting and turn it off. And it works so much better. And then, you know, obviously after the gap is closed, the goal is just glucose control. Does that make sense? Because I see so many times that the orders are just written to start the insulin and there's no overlap and the sugars become a mess.
So Dr. White, I have a question. So just to recap, once the blood sugars go below 250, 200, like range from 200 to 250, we can like just continue the insulin drip in addition to overlapping that with a long acting insulin within 4 hours, in addition to the short acting within like an hour or two with starting diet?
Yeah, I mean, you'd only give the short acting for the meal. So, you know, in a ideal world, if you wanted to do this, you would plan ahead. And so you would give them Lantus the night before. And then the next morning, you'd give them their first dose of Humalog and let them eat and then shut the drip off. That would be more ideal. Sometimes we just don't do that. There's not enough patients to do that. But that would be the best way to do it. And again, you don't have to stop the IV insulin. You have the ability, without changing the bag for the nurses or anything, to switch from the DKA protocol to the titratable protocol for the IV insulin. And that buys you time to have the overlap. Does that make sense? You have to write an order to, you know, start the titratable drip and stop the DKA protocol.
Okay, sir. But it's not like apart from the initial order set we initiate, like the DKA protocol. It's the overlapping part is not like you know, one point of the protocol.
No. It actually is part of the titratable drip protocol, but apparently it's very difficult for the nurses to see it, and so they don't often do it. They just go over and turn it off. It actually says on there when you receive the order to discontinue the insulin, make sure you overlap short acting by 1 to 2 hours and long acting by 4 hours. That does say that in the protocol, but it's not usually done. I mean, they just look at your order to discontinue and they go over and turn it off.
Got it. Thank you, sir.
Unfortunately. So we've worked on that for years. When it was paper, it was more visible, but on the computer, it's actually in there, but they have to go through several screens to find it. So if they're not familiar with it, they don't see it. It's not in their face. And so it gets not done. Just remember, Lantus is forever. Like I said, you can keep it going. And when you need to, you can start the previous regimen. And we have what you guys all call sliding scale. I would prefer that it's called supplemental insulin or correctional insulin. And if you guys want to look really good from now on, instead of ordering sliding scale, you can put in supplemental insulin and the same protocols will come up. You'll just be more correct. You know, if you add the previous 24-hour insulin requirements, you can use those. But remember to be careful about that, because if you've been giving glucose, that's not the real requirement, right? It's going to be more than the patient needs. If they're not receiving IV glucose and they're just getting normal saline, you could actually use what they're getting off the titratable drip as a basal insulin dose. So if you have to guess, for type 1, a patient's going to need between a half and 1 unit per kilogram per day. So we usually calculate, it depends on how brave you are. A lot of times I'll just start at a half a unit per kilo. A lot of people will be a little more cautious and start at 0.3 units per kilo. And remember, when you make that calculation, so if you have a 70 kilo guy, that's 35 units. Half of that's going to be basal and about half of it's going to be mealtime. So, you know, 35, half of that is 16 to 18, depending on what the sugars we're running. In patients with type 2, takes a lot more insulin. They often need 1 to 2 units per kilo. An example I give is I got called for glucose control on a patient, and the next day the resident, I happened to see him myself that night, was later, and the next day the patient was seen by the resident appropriately, saw a new patient on the list. And there was also a change in staff. So Dr. Valovich had taken over for me. And before I could talk to her about the patients, they went and saw this patient. And the resident said, Dr. Whitey saw this patient last night and he changed the Lantus from 10 units to 80 units. And that seems like a big change. And Dorota said, yeah, it really does. But before we make a decision, let's look at the sugars and let's go see the patient and let's see if we can figure out why he made such a big change. But it does seem awful big. And so they went and saw the patient and they raised the Lantus to 90 units. Okay. That patient's BMI was over 70. Okay. So 10 units was not going to make a dent in a patient like that. So keep those things in mind. There can be severe insulin resistance when you're dealing with patients. And I did the calculation like this to put her on a starting dose. And yeah, it seemed like a lot to start with, but I'm telling you, that's what it takes. Some people use a ratio. And that's fine. If you don't know what to use, the common ratios are going to be 1 unit per 10 or 1 unit per 15 grams of carbohydrate. Certainly, if they're type 1, I would use 1 to 15. If they're type 2, 1 to 10 is probably okay. Hopefully that helps you a little bit with figuring out what kind of insulin to use and how to use it. ICU goals. There's been a lot of stuff, and I have another talk I give that I like to give because it talks about the data. And I disagree with some of the conclusions, but the data is really clear. The goals currently are for ICU 140 to 180, and for some patients, even less than 140. I think you know, it depends on how good your protocol is. Our protocol for the titratable drip is really pretty good with a low amount of hypoglycemia. That's what you want to avoid. The Nice Sugar study had a lot of hypoglycemia in their protocol, and that's where some of the fear came from. Vandenberg's data was incredible, and they had extremely tight control, again, in the ICU. Goals on the, sorry, the floors are still random, should always be under 180, and pre-meal should be under 140. And you should sort of work in 3 terms: basal insulin, so that's going to be your Lantus here in the hospital, mealtime insulin, and then supplemental or correctional insulin. And you should use this correctional to determine whether you need to change the mealtime doses or the basal doses. Avoid pushing the Lantus up to cover the meals. It's just basal. And if you're dropping 200 points from bedtime to morning, you're gonna make that patient crash when they go home. So they should drop 30 to 50 points overnight, no more than that, or you're on too much. So ideally you'd have, you know, and I'd be fine with 100, 100, 100, 100, but most people say 100, 100, 100, and 140 at bedtime. Remember, fix fasting first, and then worry about postprandial. Remember to avoid hypoglycemia. That causes a lot of bouncing. You guys will see what happens when there's hypoglycemia in the hospital. The next sugar is often 350. So, and what I want to tell you is a little pearl that if you have a young, healthy woman, most of our female residents and female medical students fit this bill. At 3 in the morning, their sugar can easily be 50, and that's normal. Okay. Sorry, guys run higher. That's why I'm picking on the women. If you see a 50 in the hospital, oh my God, everybody freaks out. And they get, you know, 2 sandwiches, cookies, 3 juices, and a mint bar to go with it. And then they give an AMPA D50. And then they wonder why the next sugar is 350. You know, we have a hypoglycemia protocol that says 15 to 30 grams of carbohydrate and how to give it and whether they're awake or not awake, and to recheck the sugar in 20 minutes and to repeat as needed. So it shouldn't be the big swings that we see occurring. It's very commonly overtreated. Often true that the patients do that as home as well. Post-MI, if I had my way, they'd all be on an insulin drip. They certainly should be on insulin, I think. Probably, I got a feeling that with time that may change, because as an outpatient, for somebody who had an MI and has type 2 diabetes, yeah, we'd send them home on insulin, but I'd also, as an outpatient, think about adding Jardiance. That there's definite data that Jardiance is a good thing for cardiac patients. So if you have a variation, and we talked a little bit about this, but the patient has type 2 and the blood sugar is 800, and there's no anion gap. What's the diagnosis there?
Hyperosmotic.
Yeah, it's hyperosmolar syndrome, coma, whatever. They often say coma. I hate that because they can be wide awake. And what's the difference in treatment?
Gonna be almost the same to start with, like IV hydration mainly, and with the to start with the insulin drip?
So essentially, yes, but there is a difference. And the difference is in the insulin drip. So both of them are going to be large water deficits, need hydration. Both of them need insulin. There are no ketones in hyperosmolar state. So we don't have to maintain high insulin levels. And so in this kind of person, you would go right to the titratable drip because you don't need that insulin at 7 to 9 units or whatever you're going to run it at steady, because there's no ketones to get rid of. So your goal is simply to correct the hyperosmolar situation. The case that I like in here, I had a Hispanic guy, no history of diabetes, decided that it was not healthy to be drinking a fifth of schnapps every night. Everybody know what schnapps are? I see some smiles in what I can see, so I'll take that as a yes. So it's a German alcohol. It comes in many flavors, so you can get your flavor of your choice. And so he stopped drinking his schnapps and replaced it with a case, I think 24 cans of regular 7-Up a day. I don't know how he drank that many cans, but that's what he decided to do. And he actually didn't have any complaints. He was brought to the emergency room by his wife. She had complaints and he walked in. Her complaints were that he had to go to the bathroom a lot and it was sticky and hard to clean up because he didn't always make it. His sugar was 2,000. I'm amazed that he walked into the hospital. Shortly after walking in, we had to intubate him. He became unresponsive. So these people can have extremely high glucoses. As you would expect, the mortality rate can be much higher because the fluid shifts are just incredible. And the mortality can be up to 30%. As in this guy, it's often in an undiagnosed patient. Infections are more common. It's a higher risk of thromboembolic events, although other than your standard heparin or whatever you're using for DVT prophylaxis, nobody gets more aggressive with them. In this guy, you also want to make sure that you bring them down more slowly because you don't want these enormous shifts. And so over the next few days, I brought him down. And on about day 3, he woke up, pulled out his ET tube, pulled out his IV and signed out AMA. He said it wasn't his hospital and he wasn't staying. I said Hispanic. He was actually Native American. He wanted to go to the Native American hospital. Yeah. What can you say, right? I mean, these are real things. Causes, same kind of causes, infections, trauma, surgery, some medications, same kind of things that cause TKA can cause hyperosmolar state. Again, bring it down more gently because it's usually higher. Okay, 37-year-old female presents to the ED, severe dyspnea and anxiety, becomes lethargic, hypoxic, and gets intubated. She's 20 weeks pregnant. She was diagnosed with hyperthyroidism about 3 weeks ago, and they recommended methimazole, but she couldn't afford it. Blood pressure is 160/120, a little high. Heart rate 120 to 150 seems a little high. Respiratory rate 28, temperature 100.6, thyromegaly, no nodules, but there is a bruit, thyroid bruit. So chest x-ray shows bilateral patchy infiltrates, labs, TSH, barely measurable, free T4 greater than 6, free T3 greater than 20, and LFTs are elevated. So what's going on here?
Thyroid storm.
Toxic crisis.
Yeah, this one's storm. Um, and it's a matter of definition. And sometimes that definition can be soft, but mortality can be high, 10 to 20%, and even as high as 75% if treatment's delayed. There's usually some kind of precipitation, often surgery, can be trauma, infection, sepsis. Iodine loads seems to be popular in the health food stores to have iodine you can get for thyroid wellness, and that's just not a good idea. There's an increased response to the thyroid hormone and catecholamines, and this can be bad. Fever, delirium, psychosis, coma, dyspnea, nausea, vomiting, diarrhea, tachycardia, arrhythmia, either hypertension or hypotension. Both are bad. Ultimately, cardiovascular collapse with pulmonary edema, liver failure. Often we have a goiter, eye signs, because mostly this happens in Graves' disease, tremor, moist skin. So, you know, it's easily overdiagnosed. And so you get TFT, BMT, and glucose and calcium can be elevated in hyperthyroidism. LFTs, again, can have a leukocytosis or a leukopenia, and you got to figure out what the condition is. So case I had was a lady with Graves' disease, had not seen the endocrinologist, had an appointment. Whoops. So sorry, how do I get back to, there we go. Before, she had an appointment the upcoming Wednesday, and before making it to that appointment, she had the poor taste to be living in a small town and rupture her duodenal ulcer and require emergency surgery and repair of the duodenal rupture. That was Friday night. Saturday morning, I got a call from this little hospital explaining the situation, and I went, oh shit, this lady's really sick. I said, you got a problem. You need to do this and this and this. And they went, we're not doing any of it. We're sending her to you because this is too serious. And, you know, often I'll say, oh, this patient doesn't have storm. This one really had storm. Altered mental status, tachycardia, even on the beta blockers, IV beta blockers, she was running 150 to 180. Hypotension. Okay. I didn't think she'd make it. I didn't think she'd make it. So she did. I don't know if I'll go through all the stuff, but we'll talk about the treatment. There are criteria, and they drive me nuts. Because if you look at these criteria, what you'll see is if you add these points up, a lot of patients just in the ICU without any thyroid problem will get enough points to be in storm. And they certainly aren't. They're just in the ICU. And that's what bothers me about these scores is that sick people are sick. And they're sick for a variety of reasons. And it doesn't mean they all have storm. And so that's my little pet peeve. Supportive beta blocker, most of the time, it's going to be IV when they're in storm. PTU is preferred for storm. It's one of the few situations. Otherwise, you can give methimazole if you need to. And in the case I mentioned to you, I couldn't give anything orally because of the duodenal repair. And so we developed a rectal enema that we gave, and we're able to do that. We usually give steroids and either Lugol's or SSKI. Again, in this case, I could not give oral Lugol's, and that's what you do. You put the drops in the mouth. And there's actually a, here we have both, but one of them has a marker on the dropper for the nurses to go up to, so they know how much to give. So in this lady I just mentioned, I could not do that. They wouldn't let me give anything orally. And so I had to find another way to give iodine. The book will say to give sodium iodine IV, which I dutifully wrote. And the pharmacy called me laughing and said, you know, they don't make that anymore. I said, well, it's still in textbooks. And they said, yeah, well, that's fine and good. Because I'm older, I remember that in the old days, we used betadine as a surgical scrub instead of the stuff that's used now, and everybody came out orange. And if you would do thyroid uptake on patients who had thoracic surgery or major abdominal surgery, their uptake would all be low. And so I wrote orders for this lady to be scrubbed with betadine every shift, so 3 times a day. And she absorbed enough iodine through the betadine scrubs to suppress her, and she actually survived and did well. Thyroidectomy, if intolerant, I got to tell you, if they're in storm, you're going to have a hell of a time getting the surgeon and anesthesia to be willing to take them to surgery, because if you're that bad off, the mortality rate's going to be extremely high. And those of you who have already seen, anesthesia doesn't want to take any hyperthyroid patient to surgery, and the rule is, if it's elective, you don't go to surgery if you're hyperthyroid. The risk of going into storm is high. Okay, another case, 64-year-old female brought by family to the ED after being found at home. Don't know the patient's medical history. They bought some empty boxes, pill bottles. They say Norvasc, lisinopril, levothyroxine, Colace, and Nexium. Blood pressure 100/60, heart rate 55, temperature is 95.5. Skin's pale, there's some periorbital and generalized edema, healed scar in the lower neck, distant heart sounds, and decreased EKG voltage. So what's this?
Adrenal crisis, maybe?
Mixed edema coma.
Yeah, it's the levothyroxine bottle and the scar on the lower neck imply this patient had a thyroidectomy and hasn't been taking their medication. Low voltage on EKG is about one of the few things that can cause that is severe hypothyroidism. So I always look at that. TSH was, I should change this. This is an actual case, but 120. We had an 800 the other day. So, 120 looks pretty good to me. Free T4 0.2, CK 2200. She had a pericardial effusion, but no tamponade. These are important things. We had, in the old days, a lot of patients that would come in with CK and be severely hypothyroid. And we used to do muscle biopsies on them. it's all from hypothyroidism, and those people don't need to be biopsied anymore. The pericardial effusion, this is important. I've had about 3 or 4 patients actually have tamponade and require emergent taps or windows. One of the more interesting was a guy who was admitted with hemoptysis and was put in isolation down in the ICU here for suspected TB. Okay, and with the routine labs was found to be hypothyroid, and in fact he had tamponade, and I don't know if Dr. Boigia will mention it during his talk, but one of the symptoms of tamponade can be hemoptysis. And so in fact, his hemoptysis was from the tamponade. He actually required 2 windows. They probably won't ask you on your boards. I don't even think I just redid my boards. I passed, thank you very much. The fluid from hypothyroidism, the pericardial effusion, is very pathognomonic, straw-colored, clear straw-colored fluid. So if you ever see that, you need to be thinking hypothyroid. So we got the diagnosis, and I already told you the CK is related. And what are we going to do? We have to support them. Hypothermia, so warming blankets. Mortality rate can be fairly high. The clues, I told you, the bottle of levothyroxine, the TSH, obviously the neck scar. Precipitating events can also push you over. It's the same kind of things. They present often with altered mental status, hypothermia, bradycardia, hypotension. Those 3 are the main 3. The rest of these occur, and you'll see them if you look. These are the 3 that are usually the presenting symptoms. Somebody who was out there. Often a loading dose is given 200 to 400 micrograms IV. People ask about how much to give, and you can give like 1.5 mics per kilo per day. The question is about T3. There's some data that suggests that it's helpful if it can be given right away. So sometimes we have it available and sometimes we don't. So what I tell people is if you want to give T3, it's okay if you can get it. If the pharmacy has to order IV T3, don't bother. Because after the first 2 or 3 days, it's not helpful anymore. So it's those first couple of days where it could potentially be helpful. So if you're going to give it, you have to give it right away. Hydrocortisone is worthwhile, and I would do it. And then you have to figure out the precipitating cause as always. Okay, 26-year-old with type 1 diabetes brought to the ED for hypoglycemia, found unconscious by her husband. She was complaining of fatigue, nausea, dizziness for a couple months, more hypoglycemia on her usual doses of insulin, appears tired, tanned, afebrile, blood pressure is a little soft, heart rate 94, sodium low, 132. Glucose was 28 and then 65 after D50. What do you think now?
This is adrenal
Maybe
crisis.
Addisonian
There you go.
crisis.
Now we're at the adrenal. Very good.
She's tanned.
She's tan. That's the hint there. She's tanned. And so that's primary adrenal. Secondary adrenal doesn't always get the tan. So but to make it easy, the spinal. So
No
obviously,
electrolyte imbalance. Yeah.
we need steroids, right? So, and remember that all our hormones have circadian rhythms. Growth hormone is pulsatile. And so measuring growth hormones for anything usually isn't very advantageous. Measure an IGF-1. So yeah, this patient's in adrenal crisis. And again, there's usually something, hemorrhage, infarction, pituitary apoplexy, infection, stress superimposed on underlying adrenal insufficiency, shock hypoglycemia. And so, I mean, it's steroids and fluids. In primary, you're going to also need Florinef. In secondary adrenal insufficiency, you don't need the Florinef. Symptoms, malaise, fatigue, weakness. Of course, you guys are all fatigued, so maybe you need a little steroids. Anorexia, nausea, vomiting, weight loss. There's volume depletion, sometimes causing orthostatic changes, hyponatremia, hyperkalemia. Now, having said that, it doesn't have to be overt. So, if it's over 4, it's consistent with adrenal insufficiency. So don't say, oh, well, it's only 4.3. It's not high. It can be in the upper part of normal and still be adrenal insufficiency. It's one of the causes of hypoglycemia. Primary has the pigmentation, secondary does not. People have sexual dysfunction and depression, impaired memory. Secondary, a lot of the same things. Anorexia and weight loss is less common. And no salt wasting. They don't have the hyperkalemia and the pigmentation. So that's the major difference. High renin and low aldosterone. Cortisol, ideally at 8 a.m. Less than 3 is deficiency. These numbers slide around a little bit. For a while, it was less than 5. They've dropped it, I think, to 3. Some people even want to drop it to 1.8, but I think less than 3 correlates pretty good. For a while, we used 5. That didn't, a lot of people passed the cosentropin stim test, even when they were a little less than 5. So over 18, you're probably not deficient. And you can get a random cortisol. Remember that if they're under stress, their cortisol should be elevated. So if somebody comes in really sick, you can grab a cortisol. If it's high, they're not adrenally insufficient. Okay. Cosentropin stimulation test. I actually saw somebody, I don't know if it was yesterday or last week, but that they ordered a cosentropin stimulation test in their clinic to go down to the lab and get it. The lab can't do this test. So it can be done in the hospital as an inpatient. Otherwise, we do it in our clinic. It's not done anyplace else. And that's because the lab can't administer any medications. And so you draw baseline labs, ACTH and cortisol, and then you give 250 micrograms of cosentropin. IV, if possible, you can give it IM. And then 30 minutes and 60 minutes later, you draw cortisol post ACTH is the way the lab is ordered. And actually, you won't have to worry about that if you click on the cosentropin stimulation test protocol that's in the computer. It's life-threatening. So if you're not sure, draw labs and give the steroids if you have to. Give them fluids. Try and use dexamethasone. Dexamethasone will allow you to still do the cosentropin stimulation test. Once you start hydrocortisone, you can't do the test anymore. If you think it's primary, and again, pigmentation, they'll need Florinef as well. And then again, look for the cause. A lot of times it's just missing their medications and running out. We encourage them to wear a medical alert bracelet. Hydrocortisone, common doses are 20 milligrams in the morning and 10, it's supposed to be like late afternoon. Or prednisone 5 and 2.5. These doses in some patients will still result in them looking cushingoid, indicating it's too much for them, and we would taper down. Stress doses are double these doses. Sometimes the mistake is made that it's double your dose. If somebody's on 10 and 5 of hydrocortisone, they should quadruple their doses. You want to get to 40 and 20. Okay. There's not a blood test to assess whether you're at a good level or not. So some people will measure the renin to control the Florinef dose. Most people don't give DHEA, so I wouldn't do that. Secondary, same treatment, but no Florinef. One little side point, unless you want to get in trouble with somebody who's hypothyroid, if you have both, give the steroids before giving the levothyroxine. Otherwise, you'll induce an adrenal crisis. Now, you can do it at the same time, but don't. And give the Dex if you want to do the stim test. And just remember, you can't give it to them for a week and then do the stim test. That won't be very helpful. But if you're for 24 hours, you can, set it up so you can do the cosentropin stim test. Coverage for surgery should be stress doses. I did really 50 every 8 is probably adequate for most things. In the ICU, you'll often see that we will give 100 Q6, and that's fine too. That's more than most people need, and that's all right because you're doing it in an unstable situation. If they were stably stressed and needed IV stress doses, I'd try to give the lower amount that I could. For a lot of procedures that patients go through, we just give them a single 100 milligram IV dose before endoscopy or cath or whatever. And that should be adequate because the expectation is that's not going to be prolonged. Let me see what I want to say about here. Yeah, there's discussion about septic shock, and some critical care specialists use steroids in a lot of situations. There's data going both ways, and so I don't feel strongly about that. When somebody's unstable, you'll find that a lot of people will give high dose steroids, period. But it's an unstable patient. The rest of this is more esoteric. How am I doing? I know that's a lot. So where am I? Any questions or concerns?
Yes, sir. Just, I have a question about the placement of those patients when we are rigging. So all of those patients are gonna be placed in the ICU, except for patients with DKA or HHS with no altered mental status. They can be placed in the PCU. Otherwise, all of those are treated in the ICU.
So theoretically, and practically. So theoretically, they can be done anywhere in the pavilion. 3 red, 4 red, and 4 green. Now, having said that, that's theoretically. You will find that 3 red, 4 red, and 4 green are all going to balk on you. They're not going to do it.
Dr. Whiting, I have another question.
Yes.
So I was just trying to go on Sun and trying to order that insulin drip that you were talking about, the titratable one. You know what name it goes by?
Oh, so first of all, you can't be under medication.
I'm sorry.
You can't be on the medication page.
Oh, no.
It has to be on orders.
Yeah, I'm on orders and I'm trying to order it on a test patient.
Just put in insulin.
So it says insulin drip and it gives me the normal 0.3 units per hour drip. But it does not give us any parameters. So what parameters would you use?
Well, I don't know where that one came from. That's none of the protocols.
In this situation, I would communicate with the pharmacy, and this happens a lot on the ICU. Communicate with the PharmD, and you may need to put some parameters in the order.
Okay, I thought it's like May.
But it should come up as insulin, not for DKA.
Type DKA, you'll find like both options available for you, Preetham, I think.
Right.
Oh, okay, cool. Thank you.
Okay, so the titratable one says insulin drip, not for DKA, in parentheses. And then you will have to pick in the order set, usually chart 1 to start it, unless you know somebody's extremely resistant and you want to start at chart 2.
Yeah, I just found it. If you type DKA, it says IV insulin in parentheses, not for DKA order set. Yeah. Okay, thank you.
Okay.
Regarding the comment from Dr. Waidi about the septic shock, the recommendation is hydrocortisone not to exceed 200 per day. So 50 Q6 or 200 drip over 24 hours. Higher than that is harmful in the septic shock, and we'll talk about that with the shock lecture tomorrow.
Very good.
Dr. Whitey, for patients in DKA, I had one patient about 2 weeks ago. The initial blood sugar was 600, and then the BMP, so we started the DKA protocol. The next BMP that was done 4 hours later showed blood sugar of 360 something. So we continued, the anion gap was still open, so we continued it. But the next POC blood glucose showed the patient was reaching hypoglycemia at glucose of 70-ish. And in that situation, would you then go ahead and put the patient on D5 half normal saline right away?
Yeah, you're actually behind. They should have been already on the D5.
Okay.
It just switched a little bit. You can keep talking. I have to plug in.
Okay, so you can use a POC glucose as a guide, not just the serum.
Oh
Okay.
yeah, absolutely.
Okay.
I mean, because you're checking the point of care every hour,
Okay.
and you might get a BMP every 4 hours.
Okay.
So yeah, by all means, we would say add the D5 based on the point of care glucose.
Okay. And another question is, this is a rare situation, but do you do plasmapheresis for patients with in refractory thyroid storm, or that you can't give MTU or PTU for because they have severe liver disease, or severe leukopenia?
You know, that's a really interesting question. I have no idea what the books will say about this. We have an abstract about doing this, and so our answer would be yes. You could do that, particularly when it's from Graves' disease, because you're getting rid of the antibodies, and you can plasmapherese them off. It looks like it's fairly effective. It's sometimes a bit of a hassle to set it up and get it done, depending on the time of day and stuff like that. But my answer would be, yeah, it actually works and seems to work well. Obviously, you're gonna still have to do something, because that doesn't cure them, right? It makes them better and more stable so that you can do something long term, but you still got to do something long term. But yeah, I would say you can do that. You also can probably do it for severe triglycerides too. You know, and the change has become that it's just more available than it used to be. You know, plasmapheresis used to only be done at a couple centers, and you'd have to send people out, and you could only do it between 8 and 5 during the days, and Monday through Friday, and you know, but now it's become more commonplace, and so situations where it wasn't very common before, I think it's a reasonable thing to do.
I have a question.
Yes.
So if somebody has a underlying adrenal insufficiency, goes into septic shock, do we still need to use hydrocortisone maximum 200 milligram per day?
Well, if they have underlying adrenal insufficiency, I mean, theoretically, 50 Q6 should still be adequate. A lot of people would, in that case, give 100 Q6 and you'd be at 400. I don't know. What do you think?
I think it's a clinical assessment. Also in the septic shock, there is some study that showed improved mortality with hydrocortisone plus fludrocortisone. So you give 50 Q6 plus 50 fludrocortisone in the NG or so. But if your patient is still hypotensive, you can try to increase the dose. The thing is, with above 200 with septic shock, you may worsen the outcome because of the infection. But it's a clinical judgment. I usually give 50 Q6 with the 50 microgram of fludrocortisone and the NG, and then or orally if the patient is awake, and then assess if you need higher. So, yeah,
I think the difference in the patient he was talking about was they had underlying adrenal insufficiency. So yeah. I don't know that we have data that much in those patients, but again, theoretically, 50 Q6 should be an adequate dose.
Sure, thanks. I have another question. So regarding in patient with thyroid storm, I mean, do we need to follow any sequence in terms of what to give first, propranolol, PTUs, steroids, or it doesn't matter what do we get first?
You know, I don't know that we have data on which order. There's a practicality to it. And the practicality is the easiest thing to give first is fluids and IV beta blocker, because that's readily available in every ICU and every hospital. And so that's what's going to be first, just by default. And it should be PTU in storm. The two places for PTU are storm and the first trimester of pregnancy for hyperthyroidism. Otherwise, methimazole is the preferred drug for hyperthyroidism. So, but that's going to come from the pharmacy, and there may be a delay, and so and it doesn't work right away. I think the most important thing, the first thing, is beta blockade.
Thanks.
Thank you very much, Dr. Whitey. We appreciate your time. Great teaching. And thank you, everybody. We will get 5 minutes exactly as a break. We'll come back. I'll put some music to share with you during the break. And, okay, so just be in time so we can finish in time. We have only one more lecture to go. And thank you for your patience. And we'll go from there. Thank you, Dr. Whitey.
Oh, you
Thanks,
bet.
Dr. Whitey.
Thanks.
You're welcome. Okay, I hope everybody is back. I'll start to share the screen for the last lecture. And we will talk about the pneumonia. Okay, do you see my screen now?
Yes.
Okay, great. So again, if the slides don't move, let me know. So we will talk about pneumonia, and we will talk about different types of pneumonia, the community-acquired pneumonia 2019 guidelines, the hospital-acquired pneumonia 2016 guidelines, same with the BAP 2016 guidelines, same guidelines with the HAP. The COVID-19, we'll talk about COVID-19. I have multiple slides for you, but I may not have time to talk about everything. But maybe for COVID-19, I will have the website that you can check, because it's very dynamic and things change in the management very frequently, every maybe few days. Okay, I have no disclosures. The objectives by the end of this lecture, everyone will be able to recognize the severity of community-acquired pneumonia, which is an important thing to tell you where to treat your patients, identify need for ICU admission for community-acquired pneumonia, identify hospital-acquired pneumonia and ventilator-associated pneumonia, send proper diagnostic labs, and describe proper empiric antibiotics, recognize COVID management websites. Okay, so I will start with the case. I have a 39-year-old woman, previously healthy, came to the ED in January. I have certain things I want you to pay attention to that I put in red. She came to the ED in January with 5 days history of upper respiratory symptoms, dry cough, malaise, myalgia, and subjective fever. 1 day later, she noted the dark color of the urine, right upper quadrant pain, and had diarrhea and vomiting. Okay, so anybody, can you tell me when you have these things like jaundice and diarrhea with pneumonia, what should you think about? Any thoughts?
Viral infection, leptospirosis.
Okay. Also, you should think about Legionella, especially also if you have hyponatremia with that in your board. Diarrhea, hyponatremia, jaundice with pneumonia, think about Legionella too. She came with sneezing, noted during the interview, and husband noticed confusion for 2 days. She smokes pack per day, 20 for 10 years, no recent travel, no pets, no occupation exposure. She lives with her husband and no risk for HIV, no known drug allergy. On exam, she's confused. Respiratory rate is 18, oxygen saturation 98% on 2 liters, so she was hypoxemic on room air. Blood pressure 106/72, febrile 103.2, and tachycardic 136. Chest right anterior and posterior bronchial breath sound and has crackles. Abdomen soft, mild right upper quadrant tenderness, skin slightly jaundiced, and rest of the exam is normal. These are initial labs. White cell count is 11.7, and she has bandemia 46%. I want to stress on the bandemia because sometimes bands can be the only thing that tells you this patient is septic. Especially in immunocompromised people, you may have white cell count 5,000, 6,000, and no fever. And the patient comes with altered mental status and you don't know what's going on. Then later on, you get bands 20%, 40%, and this is the only thing that tells you your patient is septic. And because of his low immunity, he's not having leukocytosis, does not have fever, and this is something that you need to pay attention for. Above 10% bands is very specific for sepsis. Only other thing I know about that can cause that if you give bone marrow stimulant after chemotherapy or so. Also, platelet is low. This is important for the severity, 90,000. Sodium is 125, creatinine is 1.1, BUN 21, and BUN is important for the severity. Bicarb is 19, amine gap 16 with lactic acid 4.2 and slightly elevated liver functions. This is the chest X-ray. We see here bright lower lobe infiltrate because we don't see the right hemidiaphragm. Also, we don't see the right costophrenic angle, so maybe some effusion on the right side. But also, I want you to note these infiltrates, right upper lobe, left upper lobe, and behind the heart, this is left lower lobe, and this is multilobar pneumonia. This is important when you determine the severity of the pneumonia, if you have multilobes. Okay. I'll ask you certain questions, and please answer me yes or no for these questions. If you can, if you would like to send me a message on the poll everywhere, or if you would like to just unmute yourself and say yes or no, or send that in the chat, everything is available for you. Okay, so these are the 16 questions that they answered in the somebody sent me a message. It's Legionella, so that's correct. Somebody sent me a message about the concert that was played before, so that's correct. Anyway, these are 16 questions that were answered, or they asked and answered them in the pneumonia 2019 guidelines, community-acquired pneumonia 2019 guidelines. Will you send sputum, gram stain, and culture? Yes or no?
Yes.
Yes.
Okay. For this patient, probably is reasonable, and we'll talk about. Will you send 2 blood cultures?
Yes. In this patient, yes.
Okay. Will you send urine strep antigen and Legionella antigen?
Yes.
Yes.
Yes, we said she has some hyponatremia, jaundice, and diarrhea. With pneumonia, you should think about strep. Strep pneumonia is the commonest cause of pneumonia, even in immunocompromised. So for severe pneumonia, reasonable to send them. Will you send influenza test? Remember,
If it's in season.
Yeah, she came in January, so probably reasonable to send. Well, now will you send COVID test? Definitely, for sure, you will send that test. Okay, it's not in the guidelines, that's why I put it in black, but definitely for now, you will need to remember the guidelines is before the COVID. Question 5, will you use procalcitonin to help you to decide if you start antibiotics or not?
No.
No, right? So next question. This patient is in the ED. Where will you manage this patient? Outpatient? Admit to the floor? Admit to ICU? Anybody would like to manage this patient as outpatient?
No.
No.
I think that's the floor.
So you want floor?
Yes.
Okay. Anybody wants ICU?
Depends if in how septic they are, whether they need fluid support or not.
Based on the data that we have, do you think she needs ICU or she needs floor?
Not yet.
Floor for now.
Floor for now. Okay, we'll talk about that a little bit. Okay. Do you see my slides moving? Question 6.
Yeah, we see.
Okay. So to decide between outpatient and inpatient management, did you use clinical judgment only, clinical judgment plus curve 65, clinical judgment plus pneumonia severity index?
B.
B.
C.
Okay, so C. Did I
B
hear
and
B
C
too?
together.
I think it's B for the placement, and the PCI for PSI for the prognosis.
Okay, we'll talk about that also. So we have some room of changing mind. Okay, and question 7, to decide between floor versus ICU management, did you use clinical judgment only or clinical judgment plus the ETSA ATS 2007 severity criteria? They did not change the criteria in 2019. They used the same criteria that was used in 2007. Anybody used B or just A? Anybody
Just A.
heard about the ETSA ATS severity criteria before? If not, you need to know that. You need to have it on your phone when you admit any patients with pneumonia, or look at it in the up-to-date or on the, I think I sent you the article for the guidelines for the 2019 community-acquired pneumonia. Okay, question 8 and 9 and 11, based on your site of management, looks like nobody said that you will manage on the floor, but if you manage on the floor, nobody said will manage as outpatient. If you will manage on the floor, what antibiotic you will use? If you admit to the ICU, what antibiotic you will use? Just write your antibiotic. I'll give you a few seconds to write your antibiotic. You don't have to share it now, but just write your antibiotic and correct yourself after we discuss the guidelines. Okay. Question 10. If you suspect aspiration, would you add an aerobic coverage for this patient? Yes or no?
No.
Yes.
Yes?
No.
No.
No. Okay.
No.
Okay. Everybody's
Yes.
saying no? Anybody wants yes?
I think yes.
You think
I thought yes, sir. I'm not sure why not.
Why not? Okay. So we'll talk about that too.
Yes.
Okay. So yes or no, we have specific things to decide yes or no for anaerobic coverage. Great. So question 12, would you add steroid? Yes or no?
How
No.
much are oxygen saturation?
No.
Cover
No.
if the separation is there.
Okay. So we have no, and I think somebody's saying yes. Okay. So we'll also get to that. If the patient tests positive for influenza, would you treat for influenza? Remember, the patient had symptoms for 5 days. Yes,
Yes.
or no?
Yes,
No.
you treat.
Yes.
No.
Yes.
No, after
Okay.
5 days, you
Yes.
don't treat for influenza
Okay.
symptoms.
Okay. So looks we have some yes, some no. Okay. We'll
Treat for
correct.
the 48 hours only, initial 48 hours.
Yes, you don't treat after that.
Okay. We'll correct this idea a little bit. Okay. So question 14, if the patient tests positive for influenza, would you initially cover for antibiotics in addition to covering for the influenza if you will cover? Yes or no?
Yes.
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 So this is after the 5 days with the same presentation?
Yeah, so the patient came. This is a general question. They are not talking about my case and the guideline. They're talking in
Okay.
general. Okay.
Oh, okay. So if it's general, then no. But if this case, then yes.
So in general, if you have a patient admitted and influenza positive and you have pneumonia and the X-ray, you don't want to cover with antibiotic.
But you do,
Excuse
because
me,
they can
Dr.
have
Gohar. So
superimposed.
influenza is the viral, correct? It's not the Haemophilus influenzae, correct? It's the influenza, the viral.
Haemophilus influenza is a bacteria, so it's completely
Yeah, so the viral, no.
No? Okay, we'll have some room for correction for that too. Great. What is the appropriate antibiotic duration? 7 days, if no complications, abscess, empyema, necrotizing pneumonia for our patient. So 14 days for MRSA and no complications. Less than 5 days if clinically improving.
A?
7 days.
7 days.
Okay, so 7 days. So I heard B also for 14 days for MRSA.
So there is room for correction.
Okay. Okay, we'll have some room for improvement. Okay, question 16, patient got better and you discharge the patient. Do you need to follow up chest X-ray if the patient got better within 5 days?
No.
No chest X-ray.
No chest X-ray. Okay, so it looks like we have some mixed answer for some of the questions. Some of the questions we agreed for, so let's see what they say. This is a 2019 ETS, it's a guidelines. And this guideline is mainly for patients in the US with no travel. So I'm not sure they apply for every patient or patient who traveled and came from a different country. Okay, this is not for immunocompromised. I just wanted to stress on that. Immunocompromised, they should manage somewhat different. And this mainly covered the common bacteria that affect the lungs, especially strep pneumo, Haemophilus, Mycoplasma, staph, and chlamydia, moraxella, and also we will talk about gram-negative, including Pseudomonas. These are the 16 questions that I asked you, and then we'll go through the answers from the CAP guidelines. So here they say if you're, it's difficult to differentiate between viral and the bacterial. So always when you have somebody coming with influenza, initially cover influenza pneumonia, not just influenza upper respiratory syndrome. Usually you need to cover with bacterial initially, and we'll get to that. Also, for the MDR organisms that they are covering, they are mainly talking about MRSA and Pseudomonas, but they assume that the other gram-negative rods will be probably responsive to the coverage for Pseudomonas. Okay, this is very important to know. This is 2007, it's ATS severity for pneumonia. We have major criteria and we have minor criteria. I'll start with the major criteria first. Two major criteria, and definitely everybody will think this is severe pneumonia if your patient is septic and requires pressors in shock. And if your patient is in respiratory failure requiring mechanical ventilation, then definitely this is severe pneumonia, right? Nobody will argue about that. If you don't have any of these criteria, septic shock on pressors or respiratory failure requiring intubation, then you need to assess using the minor criteria, and you need 3 of the minor criteria. Remember the CURB 65, and we'll add to them 2 things missing in the CURB 65 was the multilobar pneumonia and the hypoxemia. Then we'll add some laboratory data that tells you that your patient is significantly sick, leukopenia, thrombocytopenia, and hypothermia, and hypotension requiring aggressive fluid resuscitation. So respiratory rate 30, PF ratio less than or equal to 250, multilobar infiltrate, confusion, uremia, BUN 20 or more, and leukocytosis, leukopenia less than 4,000, and thrombocytopenia less than 100,000, hypothermia less than 36 degrees centigrade, and hypotension requiring aggressive fluid resuscitation. If you have 3 of those, your patient is severely ill. Okay, first recommendation, adult with community-acquired pneumonia, should gram stain and culture for the sputum be done? Here is the recommendations. So in all what I will talk about, notice recommend or suggest. Recommend is a stronger recommendation, and suggestion is something like weaker, okay? And then also look at the severity of the recommendation. Is it conditional or strong or weak recommendation? So look at the quality of evidence. So for outpatient, patient with pneumonia, if you decided that you will treat the patient as outpatient, they recommend not to send sputum, gram stain, and culture. So outpatient, no. They recommend obtaining gram stain and culture for the following. If you have any of the following: severe, based on the severity criteria that we just talked about. If you start antibiotic to cover MRSA and Pseudomonas, you have to send sputum culture. But don't delay your antibiotic waiting for the sputum culture. If your patient had previous infection with MRSA or Pseudomonas, you need to send sputum culture. If your patient got IV, not oral, antibiotic within the previous 90 days, you need to send the sputum culture. Okay, how about 2 blood cultures? Again, they recommend not to send blood cultures for your patient if you decided to treat them as outpatient. They suggest not routinely obtaining blood cultures if they are not severe. So this is suggestion. So your patient, you decide he's not severe and you're treating him on the floor, you may not send the blood cultures. I usually like to send blood cultures even on the floor. This is suggestion, so it is a weaker recommendation, and also it is conditional recommendation. So very low quality of evidence. So I still send blood cultures for patient on the floor. But if you don't send for patient on the floor with the non-severe pneumonia, you are not wrong, okay? But I still recommend that, I usually send them. But they recommend obtaining 2 blood cultures before you start the antibiotic for same criteria that you send the sputum, severe community-acquired pneumonia based on the table, patient that you decided to empirically treat for MRSA and Pseudomonas, patient had previous infection of MRSA or Pseudomonas, and patient who received IV antibiotic in the previous 90 days. Okay. Third question, in adults with community-acquired pneumonia, should we check Legionella and urine strep antigens? So the question is answered. They suggest not routinely to send that for your patients, except if your patient has severe community-acquired pneumonia. So if your patient has severe community-acquired pneumonia based on the criteria we talked about, they recommend to send the strep antigen and the Legionella. Also, if your clinical condition or if there is some Legionella outbreak, you can do that. And when you send the antigen, and also we can send urine antigen for the Legionella. Also, we can send BAL if we brought the patient Legionella antigen. Also, they recommend if you can send culture for the Legionella in the specialized culture. Question 4, community-acquired pneumonia. Should respiratory sample be tested for influenza virus at the time of diagnosis? And exactly like what you said, if you are in the season of influenza or there is outbreak or something like that, you should check for the influenza. And this patient was in January, I would check for influenza. Okay. Question 5, in adults with community-acquired pneumonia, should serum procalcitonin plus clinical judgment versus clinical judgment only to decide for antibiotic? And they recommend not to use the procalcitonin at all to decide if you start antibiotic, only use clinical judgment to start your antibiotic. You can use the procalcitonin to de-escalate, but remember the one sample may not be positive, and if the patient comes very early in the pneumonia, it may take 6 hours and escalates within 24 hours. So you may need to repeat it within a couple of days. Question 6, should the clinical prediction rule the prognosis plus clinical judgment versus clinical judgment alone to be used to determine inpatient versus outpatient? And they recommend, we had some people discuss that, and this is the correct answer. They recommend that you use the pneumonia severity index to decide if your patient will be admitted or not. You can use the curve 65, but stronger recommendation for the pneumonia severity index. I know it is longer, but you may have it on app or on up-to-date, so you can use that. It is stronger recommendation. You see the curve 65 is a conditional recommendation. Question 7, should clinical prediction rule for prognosis plus clinical judgment versus clinical judgment only be used to determine inpatient general medical versus higher level of ICU? So will you admit to the floor versus ICU? And they recommend that you use the ETSA ATS 2007 severity. If you have severe pneumonia, you probably need to admit the patient to the higher level of care, ICU, or at least PCU. If you have non-severe pneumonia, you can admit to the floor. Okay, and the outpatient setting, which antibiotics are recommended for empirically to treating the pneumonia? So I think nobody wanted to treat this patient as outpatient, but if you have a patient and you wanted to treat as outpatient, what antibiotics you will use? And I would like you to divide the patients into 2 categories for outpatient treatment. Category 1, you. Who's you? You are young, healthy, with no comorbidities and not alcoholic. This is a category. The other category is not you. Some older people with comorbidities or alcoholic. So different antibiotic treatment. And this is a board question. For some young, healthy person with no comorbidities and no risk factors for MRSA or Pseudomonas, you need to use amoxicillin or doxycycline or macrolide. Don't use quinolones for these people, okay? And one thing I want to stress on the macrolide here for the outpatient, and this is the only time you use it, this dose is outpatient, not for floor or ICU. Macrolide is 500 first day, 250 the other days. So azithromycin for floor or ICU, we'll talk about that later, is 500 every day, okay? amoxicillin is the strongest in the recommendation. So, but all are okay. If your patient is not you or has comorbidities, you can use similar to what you do on the floor, either fluoroquinolone alone, or you combine amoxicillin, clavulanic acid, or cephalosporin. I need to pick oral cephalosporin, and you have those in the bottom, and I will show it in the next slide too. And instead of the, usually we use Unison and Unison or ceftriaxone for the inpatient, but these are IV. So for outpatient, use Augmentin, which is nearly equivalent to the Unison because it's orally, and the cephalosporin, the cefuroxime, and some others, cefodoxime. These are oral cephalosporin, and combine that with azithromycin. So either quinolone or combined either beta-lactam, cephalosporin, or Augmentin plus the macrolide or doxycycline. Okay, so this is the slide. So healthy person like you see the amoxicillin 1 gram 3 times a day. I'll not go through the doses much for the sake of the time, but the strong recommendation, okay, versus doxycycline or macrolide, they are conditional recommendations. So stronger recommendation for young healthy person with no comorbidities, no risk factors for MDR as outpatient is the preferred amoxicillin, unless they have penicillin allergy. For not you, this is the recommendation with their doses. So either quinolone alone, monotherapy, or combine 2 antibiotics between either Augmentin or cephalosporins like cefuroxime or cefodoxime, plus macrolide or doxycycline. Again, the dose for the outpatient 500 first day for the azithromycin, then 250 the rest of the days. Clarithromycin also can be used instead of the azithromycin. Okay, how if you admitted the patient to the floor versus the ICU, or if you consider that your patient is severe or non-severe pneumonia. This is very important. Here on the top, we will have the non-severe, and here is the severe. I'll start with the severe first. These are your patients that you will manage in the ICU, and you need to start proper antibiotic. For community-acquired pneumonia in the ICU, in your board exam, if you have 1 antibiotic as an option, don't pick that antibiotic. It is 2 antibiotics, okay, different from the floor. So either beta-lactam plus macrolide or beta-lactam plus fluoroquinolone. This is in the ICU. The beta-lactams that we usually use is Unison or ceftriaxone. Here they say the ceftriaxone, if you look at the bottom, 1 to 2 grams a day. I would prefer for the severe pneumonia that you use 2 grams for the ceftriaxone every day, single dose, 2 grams, single dose. For the macrolide, it's 500 every day, not 500 then 250s. Same thing, if you decide that it's not severe on the floor, you can do that at the outpatient with comorbidity, either quinolone alone, so if you use levofloxacin and the dose is 750, or combined beta-lactam, you can use ceftriaxone 1 or 2 grams. I also prefer to go to 2 grams of the ceftriaxone, even on the floor, and the macrolide azithromycin 500 every day. You can use, instead of the ceftriaxone, you can use the Unison. Okay, similar in the management, if your patient had previous MRSA, you need to cover the MRSA and send nasal swab for MRSA, please. Also, we sent already the cultures. If your patient had previous Pseudomonas, you need to cover for the Pseudomonas. So no difference between the severe and non-severe. The difference will be if your patient had IV antibiotics or at risk of MDR. If your patient is severe, you need to cover the Pseudomonas, and you need to cover the MRSA if you are suspecting them, because severe may not have time to wait for the cultures. If your patient is not severe, you need to send the cultures, don't start the antibiotics, and if you are thinking MRSA, send the MRSA nasal swab for PCR for MRSA. Okay. So same thing here, non-severe community-acquired pneumonia without risk factors. We discussed the treatment. Then severe, this is for severe in the ICU without risk for MDR. So you see here, your antibiotic, including macrolide, is moderate or is a strong recommendation, but it is moderate quality. If you beta-lactam plus fluoroquinolone is also strong recommendation, but the quality is less, low quality. for evidence. But both are okay. Ionisine plus macrolide, ionisine plus quinolone, or ceftriaxone 2 gram plus macrolide, azithromycin, or plus levofloxacin 750. Okay. This is a question about the aspiration pneumonia. Should your patient with suspected aspiration be covered with anaerobic coverage? And they suggest not routinely adding that and its conditions. So it is not very strong recommendation unless you have abscess or so. So if I've had somebody with lung abscess, especially in the right lower lobe, and his history suggests aspiration, I may cover anaerobic coverage for that patient. I'll talk about the people with high risk for aspiration, elderly people, people with alcoholism, and if you smell foul-smelling sputum, or if you have abscess, you probably need to cover these patients. And there is 2019 New England Journal aspiration pneumonia review article that's very good that I would like you to read, and I will have it on one slide to have the reference for that article. Question 11, in the inpatient setting, should adults with community-acquired pneumonia and risk for MRSA or Pseudomonas be treated with extended spectrum antibiotic therapy? And we talked about that. And this is a strong recommendation. And your patient with, first thing, do you remember I told you yesterday there is nothing called HCAP anymore? And this is what they also recommend, not to use the definition of HCAP. We call it community-acquired pneumonia with MDR risk. So there is nothing, this definition or this word healthcare-associated pneumonia is no longer existing since 2016. Okay. So should adults with community-acquired pneumonia be treated with corticosteroid? And this is their recommendation. They recommend not routinely using corticosteroid in adults with community-acquired pneumonia. They suggest not using routinely corticosteroid for severe. So really for severe even, they suggest it's weaker recommendation. This is a suggestion and conditional, but they suggest that not to use unless your patient is in septic shock. In this condition, you need to use your steroid based on the sepsis campaign recommendations. Okay, this is a test that we had some controversy. If your patient is positive for influenza, should the treatment begin regimen include antiviral therapy? We had people thought that if it is within 48 hours, yes. Beyond 48 hours has no benefit. You will be surprised with that. They recommend anti-influenza treatment for patients with pneumonia. Pneumonia means you have infiltrate or physical findings that suggest pneumonia, not just upper respiratory symptoms, regardless of the duration of the illness for both inpatient and outpatient. Regardless of the duration of illness. For our patient had 5 days of symptoms, you need to cover her if she tests positive for influenza with oseltamivir. Make sense? So this is something that I wanted to stress on because this is significant change from previous recommendation. Okay, community-acquired pneumonia who tests positive for influenza, should the treatment regimen in the beginning start with adding antibiotic to the oseltamivir? Yes. They recommend that you should start antibiotic initially until you rule out bacterial infection, because you cannot clinically, at least initially, differentiate between viral and bacterial pneumonia. This may be a situation that procalcitonin may help you to decide to de-escalate, but not to start. Question 15, an outpatient and inpatient adults with community-acquired pneumonia who are improving, what's the appropriate duration for the antibiotic? And they tell you it should be at least 5 days. So you remember the option, less than 5 days if they're getting better. Never treat with less than 5 days for your patient, even if they are getting better. And this is strong recommendation for the management. So your minimum antibiotic duration is 5 days, even if they are improving. In adults with community-acquired pneumonia who are improving, should you follow up chest X-ray after discharge? We used to follow X-ray like 6 weeks after discharge or something like that. They recommend not to get that X-ray. Actually, they suggest not. So you still can do it because it's a weaker recommendation. The rationale for them not to get chest X-ray, the reason you get chest X-ray to get complete resolution in case this is pneumonia on top of cancer, okay? And the rationale is that for patients who are not at high risk of cancer and don't require screening annually for cancer, the chance to have cancer is very low, like post or cancer with pneumonia on top. So the people that need follow-up with suspicion of cancer, they will qualify for the screening for cancer. You still can follow if you are suspicious because it's weak recommendation. This is a suggestion, not recommendation, and it is conditional. But based on that, if your patient is low risk for cancer and you don't follow the X-ray, you are okay. These are the differences between the 2007 on this column and the 2019 ATS ETSA guidelines. Okay. Okay, I'll just talk a little bit about the curve 65. Everybody remember the curve 65, confusion, BUN 20 or more, respiratory rate 30 or more, systolic blood pressure less than 90, then the 65 is the age of the patient. I usually used to get confused which is 20, which is 30. So to make it easy for you to remember, the numbers go up 20, 30, 90. Okay, so 20 is the respiratory rate, 30 is 20 is the BUN, 30 is the respiratory rate, and the 90 is the systolic blood pressure. Based on that, if you have 0, you can treat as outpatient, or if you have 1 and this one is age more than 65, you can treat as outpatient. If you have 1 or 2, you admit to the hospital. So 1 or 2, if one of the 2 is the age more than 65, then you should admit to the hospital. If you have 3 to 5, you may need to consider ICU admission. This is a pneumonia severity index, which that they recommended that you use to decide where you will treat your patient. And our patient scored 99, and she will be in the class 4. 1 and 2, mortality is very low. You can treat as outpatient. Admit to the hospital if you have 3 or higher. And if you have 4 and 5, consider ICU and assess for the severity criteria. There's something also called SCAP. I will not go through that much. It's very close to the pneumonia severity index that they had in 2007. And I also wanted to let you know that there's something called Smart Cup. They didn't mention much about this Smart Cup in the guidelines, but score 3 or more has 92% positive predictability that your patient may need pressors or ventilators. So probably they need to be on the ICU. Again, repeated the ETSA 2007 ICU admission requirement or severity assessment, and we talked about that. Our patient had none of the measure, but she had multilobar infiltrate, had confusion, had BUN 21, and had platelet 90,000. So she had 4 criteria, so she will qualify for severe pneumonia. I probably would admit this patient to the ICU. There are certain microbes that you need to pay attention for: Legionella, influenza, MRSA, bioterrorism, and I would like to probably add number 5 is the COVID-19. So what do you think about bioterrorism? What organism you think about?
Anthrax.
Anthrax. And anything specific in the X-ray for anthrax?
Mediastinal widening.
Wonderful. And this is due to?
Hemomediastinum.
Was that?
Never mind.
No, go ahead. Nothing is wrong.
Hemomediastinum, like blood in the mediastinum.
That's correct. Hemomediastinum that causes widened with the mediastinum. So if your patient with pneumonia with widened mediastinum, think about anthrax. Usually in the board, they don't tell you bioterrorism, but they tell you somebody who is working in wool sorter factory or has some relation to animals, like works in a farm and deals with animals and things like that, then develop pneumonia and they show the X-ray and the mediastinum is wide. Excellent. Okay. 2016 HAP VAP guidelines, and they said there is nothing called HCAP. So there is no HCAP. It's HAP VAP guidelines. What's HAP? We had that question yesterday. Pneumonia that develops after 48 hours of admission. Why 48 hours or more? Because if you develop pneumonia in the first 2 days of admission, probably you brought the organism with you. So this is probably some sort of community-acquired pneumonia. Anybody knows at what day of admission we are at risk for MDR? Anybody?
So risk for what, sir? I'm sorry, I didn't get that.
Well, what did you say?
Risk for what, sir? So you said risk
MDR.
for
multiple
MDR.
resistant. So I'll give you options. On day 5, option A. On day 5, option B. On day 5, option C. Which one you will pick?
Day 5.
All of the above.
Okay, so day 5. So on day 5 of admission, your patient is at risk for MDR. Ventilator-associated pneumonia, anybody on ventilator 2 days or more is, we call it, and develops pneumonia, they are ventilator-associated pneumonia. Causative organism, usually gram-negative rods, including Pseudomonas, and gram-positive cocci, including Staph aureus and MRSA. Okay, this is the risk for MDR, and I had this question in the pre-test yesterday. So risk for MDR, for ventilator-associated pneumonia, any prior intravenous, the option that we had yesterday, oral antibiotic within the previous 90 days, that's incorrect. Should be parenteral antibiotic within the previous 90 days. Anybody who develops septic shock at the time of the pneumonia. Any patient develops ARDS before the ventilator-associated pneumonia. 5 or more days of hospitalization, acute renal replacement therapy requirement before the VAP. Somebody is requiring CRRT, requiring acute dialysis for acute renal failure, they are at risk for MDR, ventilator-associated pneumonia. So these are the 5 risk factors. For the others, you will find IV antibiotic will give you a risk for MRSA, VAP and HAP, Pseudomonas VAP and HAP, and MDR HAP. So IV antibiotic in the previous 90 days, not oral antibiotic. Okay. How do you prevent VAP? Try to extubate as soon as possible. The most cost-effective is head of bed elevation 30 to 45 degrees, and the most cost-effective will cost $0. They love the question because they like the cost-effective management. Okay, antibiotics for VAP, and this is important. Double cover Pseudomonas, and I had that question in the pre-test. It's not just covering Pseudomonas. You have to double cover Pseudomonas and cover the MRSA. So double cover Pseudomonas. These are some antibiotics that cover Pseudomonas. You shouldn't use 2 beta-lactams. So should use only 1 beta-lactam and other group of antibiotics, okay? Because if you double cover with 2 beta-lactams and your organism is beta-lactam producing, then your 2 antibiotics are not functioning. So anti-Pseudomonas penicillins, mainly the peptaz or zosyn, cephalosporins, cefepime or ceftazidime. I don't think we have ceftazidime in the US, but it may be available in Europe and other countries. Imipenem on meropenem. We usually use meropenem. Imipenem has higher chance to get seizures, so we don't use it very much. Then the asterunam is a monobactam, but it is still beta-lactam. Then the other groups that are not beta-lactam, fluoroquinolones, cipro, and levofloxacin. We prefer to use levofloxacin rather than cipro in the hospital. Then aminoglycosides, and one thing important, never use aminoglycosides as a single coverage for Pseudomonas. They don't work, and they recommend against using aminoglycosides as a single coverage. You can combine it with other anti-Pseudomonas medicine if you will need double coverage. Okay, HAP is a little bit different. So HAP, if you have risk of MRSA, you cover MRSA. If you don't, you cover with single coverage for Pseudomonas if your patient doesn't have risk for MRSA and has low likelihood of mortality. If your patient has low likelihood of mortality but has risk of MRSA, you cover MRSA and 1 antibiotic. If your patient has high risk for mortality, you need to cover double cover Pseudomonas like the VAP and cover the MRSA. You see the 2 options that they have here in the recommendation are only the vancomycin and the linezolid. Daptomycin doesn't cover pneumonia in the lung unless you have septic emboli in the lung because the source is not the lung, it's coming from the the vegetations or so. Duration of the antibiotic. One important thing, don't de-escalate your antibiotic. Wait for at least 48 hours or 72 hours. I usually wait 72 hours, not 2 days. If your culture is 11 p.m. yesterday, don't count yesterday as a day, okay? So it is 48 to 72 hours, not 2 days, okay? All the organisms based on the new guidelines in 2016 is 7 to 8 days, including MRSA. So somebody picked 14 days for MRSA. When we were discussing that, it's 7 days for MRSA without complications. If your patient has Pseudomonas, the 2016 guidelines said also 7 to 8 days. I'm not sure, previously the recommendation was 14 days because they may develop recurrence if you use less than 14 days, but the newest recommendation is 7 to 8 days. One other important thing I would like to tell you in the guidelines, I don't have it in the slides, but if you have Pseudomonas and you covered with double cover for VAP and your patient is in shock and the sensitivity comes back, it's sensitive to both antibiotics, your patient still in pressors, don't stop any of the two antibiotics unless your patient is off the pressors. So you need to continue double coverage until your pressors are off. So this is another thing that's relatively new in the 2016 guidelines. Aspiration pneumonia, and we had that for a question. So not everybody with aspiration you need to cover for anaerobes. If you have bad teeth, that's why important in your examination for your patient is to look at the teeth. No teeth make them very unlikely to have anaerobes. So bad teeth, foul-smelling sputum, alcohol history, elderly, or if you have abscess in the X-ray or the CAT scan, you need to cover the anaerobes. These are list of the antibiotics that usually covers the anaerobic infection. This is the article that I told you about in 2019, I think November 2019, and in New England Journal. This is a very nice article. I would like you to read it. And they mentioned the high risk for aspiration pneumonia with anaerobes are bad teeth, alcoholism, elderly, and also lung abscess. Okay, I think we still have some time. We have 30 minutes. I will talk about COVID a little bit. Thanks God we have much less cases of COVID, but I would like to let you know these are nice management website for COVID. And if you know one thing about COVID from me today, know these websites because the recommendation change every few days. And what I will mention is the recommendation up to a week ago. I'll just mention those for you when I prepared this lecture last week. So, but for now, I would like you to repeatedly look at any of these websites for your most updated management of the COVID, because as I said, management is very dynamic and changes every few days. We have studies every day and we're not sure which to use. So these guidelines can help you, or you can look at UpToDate. I think UpToDate, they update it every week or so. So this may be another good source for you. Great. So when you admit or when you see patient with the COVID, you need to define what is the disease severity. What's the disease severity? And we have three groups of severity: mild and moderate and severe. Mild disease, if they have symptoms without dyspnea. Dyspnea is moderate. If your patient has dyspnea, he has moderate disease. So if they have fever, upper respiratory symptoms, some cough, malaise, all these symptoms will put them in the mild disease. But if they start to develop dyspnea, this is moderate disease. So without dyspnea, mild; with dyspnea, moderate. If they start to get hypoxemic, then they are severe. Hypoxemia definition, just I want to stress on that because people think hypoxemia is below 90%. 95% is the lower limit of normal oxygen. 94 or less is hypoxemia. So if your patient has 94% sat at rest on room air, they are hypoxemic and they are severe COVID pneumonia. Make sense? So the first group for the severe is hypoxemia that does not require oxygen, but their sat is 94 or less on room air at rest. Okay, if your patient needs oxygen, or ventilatory support, invasive or non-invasive. This is another more severe form. So the severe, will classify them into hypoxemia without need of oxygen, the SAT is less than or equal to 94%. Then if they need oxygen, we'll classify them into other groups, and we'll talk about the different management. Low flow oxygen, what we mean by low flow oxygen is less than 10 liters. Okay, less than 10 liters per minute. Once they reach 10 liters per minute, they are on high flow oxygen. Then if they need non-invasive positive pressure ventilation, or if they need ventilator or ECMO. So these are the grades of the severity. Some other groups, they classify, this is the FDA classification for the severity that we talked about. Some other groups, they add the X-ray or CT finding. If they have more than 50% involvement in the CT, they consider them as severe. If they are tachypnic, they are severe. One important thing to pay attention for, if your patient has dark skin, be careful, because dark skin can overestimate the SAT. So if the patient is satting 95%, his real may be 92 or so. So it can be switched from the mild or moderate to the severe if the SAT is read appropriately, because dark skin will overestimate the oxygen saturation for your patient. That's why sickle patients, most of them have dark skin, and in this condition, we like the SAT to be 95%. We are not okay with SAT 90% for sicklers, because 90% may be 85, 87%. There is 2 to 3 to 4% overestimation of the SAT with the darker skin. Great. So this is some recommendation for labs, what to check and what to repeat from up to date. I will not go through that much, but the initial recommendations to get CBC, complete metabolic panel. So this will include liver function, CK, and CRP. Repeat every day or every other day, the PT and the D-dimer, and some other based on the patient condition. So this is a severity classification, and this is what we talked about previously, but this is a nice graph from up to date. These are the acute parameters, and I want you to pay attention to that, because these parameters, the D-dimer, CRP, LDH, troponin, ferritin, CK, and the lymphocyte reduction, if your patient has mild or moderate and has all these symptoms, they may progress quickly to the severe, and they may need to have some specific attention to what they do, and we'll talk about the recommendation for that. Okay, I'll talk only about the recommended treatment for hospitalized patients, not for the outpatient. This is out of the scope of the course, but definitely you may need to look at the outpatient. You may face that in your clinic or so, but for the critical care course, I'll just mention the recommendation for the admitted patient to the hospital. If your patient is non-severe, the recommendation is to use supportive care only and close observation. So usually monitor their oxygen saturation, monitor their symptoms. So non-severe, mild or moderate, supportive care only. If your laboratory abnormalities with the mild to moderate, like the previous table that I showed you, are high, then in this condition, you may need to prioritize. If you have any studies going on, let your patient be involved in this study, observe them very well, and you need to consider monoclonal antibody therapy for your mild and moderate that does not require oxygen. The FDA approved the convalescent plasma for everybody, and also for same for remdesivir, that for everybody who is hospitalized, regardless of the severity. But we'll talk a little bit about the function of that. So convalescent plasma is very controversial now. We used it a lot in the beginning, but now the benefit is very doubtful. Okay, so up-to-date recommends don't use convalescent plasma outside the clinical trials. So for anybody, don't routinely use remdesivir for your patient who is non-severe. I will talk about the most likely to benefit from the remdesivir is the severe on low flow oxygen, and this is the only group that showed some improvement in mortality. They recommend for non-severe, don't use dexamethasone. I know there are many protocols in the world that have steroid for patients at home, but this is the recommendation. Don't use steroid for patients with non-severe disease. Okay, if your patient is severe, then we have different story, and we'll classify these people to patients with hypoxemia or no oxygen, 94 or less sat on room air at rest. These patients may benefit from remdesivir, and they suggest not to use dexamethasone or tocilizumab for these patients. The remdesivir for these patients may improve time to recovery. Don't use steroid. For these patients, SAT 93, 92, you can consider the remdesivir. Okay, patient receiving low flow oxygen, less than 10 liters of oxygen. This is how we define the low flow oxygen. Then you need to start the dexamethasone, improves mortality. And in this group, remdesivir also improves mortality. Tocilizumab can be used in these patients on low flow oxygen, case-by-case assessment. So if you have some elevated markers, especially CRP above 75, or your patient on the steroid and his oxygen requirement is escalating, consider using the tocilizumab for these patients, even if they are still on low flow oxygen. How about patient on high flow oxygen or non-invasive ventilation like CPAP or BiPAP? Again, anybody with hypoxemia that requires oxygen, use dexamethasone. This is the strongest recommendation, good study, and all the guidelines recommend to use dexamethasone for any patient on oxygen. If your patient is worsening or your patient is recently admitted within the first day or two, recommended to add tocilizumab to the dexamethasone, but don't use the tocilizumab without the dexamethasone. You have to add it to the dexamethasone. They also suggest remdesivir for those patients, but if you have shortage, save it for the patients who are on low flow oxygen, because these are the group that showed improved mortality. Okay, now your patient is sicker and they are requiring mechanical ventilation or ECMO. So dexamethasone, and you can add to that tocilizumab. So not routinely using remdesivir in this population, they may not benefit from that. If your patient has contraindication to steroid, then you can use the remdesivir plus the baricitinib. Okay, combination of the remdesivir and the baricitinib in the patients who have some contraindications to use the steroid. They recommend not to use hydroxychloroquine or chloroquine, not to use lopinavir or ritonavir. So this is, they recommend also don't use convalescent plasma or monoclonal antibodies for hospitalized patients unless it's a trial or so. Okay, now we discuss the treatment for patients who with mild and moderate, then the severe, the options for treatment if they are hypoxemic with no oxygen requirement, if they are on low flow oxygen, if they are on high flow oxygen or non-invasive positive pressure ventilation, and the last group, severe on ventilator or ECMO. I'll talk a little bit about few of the common medication that we use, and I will start with the steroid, because this is the most important. Who will need steroid? Anybody who will need oxygen should be started on the steroid. Definitely if they are needing more than the oxygen, like non-invasive positive pressure ventilation or invasive ventilation or ECMO, they should be on steroid. What kind of steroid? The study was done in Europe was 6 milligram PO or IV. One important thing that I put it here in red, the 6 milligram IV in Europe equals 8 milligram IV of dexamethasone here in the US, because the composition or the salt component of the product is different. And I have an article for that. If anybody's interested, I can send it to you. Just send me email and I can send you this article. So 6 milligram PO in Europe equals 6 milligram PO here. But if you need to give dexamethasone IV in the US, you need to use 8 milligram, because the 6 milligram IV in Europe that was studied equals 8 milligram IV here. Okay, if you don't have dexamethasone, you can use other steroid, hydrocortisone, what will be equal to the 6 milligrams, 150 milligram hydrocortisone. Solimidrol or methylprednisolone is 32 milligram, prednisone is 40 milligram. How long? 10 days or until discharge, whatever is shorter. So if your patient is discharged before 10 days, you don't need to continue the steroid as outpatient. Same thing for remdesivir when we talk about remdesivir. Does it have mortality benefit? Yes. At least in average 17% relative reduction in mortality, more reduction if you are on ventilator or ECMO, 36% relative reduction compared to 18% reduction if you are on non-invasive or high flow oxygen. Okay. Remdesivir, who will benefit from the remdesivir? The most likely to benefit is people on low flow oxygen. These are the most likely because they may have some improvement in mortality. Other patients, they may have reduction in the, or quicker improvement, reduction of the days of illness. So high flow oxygen and others may not have the same benefit from the patients who are on low flow supplemental oxygen. These are the most likely to benefit. Okay, dose 200 milligram first dose, then 100 milligram daily. 5 days versus 10 days. This was extensively studied, and the recommendation 5 days if your patient is not improving or worsening and requiring ventilator or ECMO, you can extend to 10 days. If your patient is ready to be discharged on day 3 of remdesivir, you can stop it. Don't delay the discharge to give him the remaining 2 doses. Benefit, it may reduce time to recovery in all severe patients, but the most likely to benefit is patient on low flow. As we said, it may reduce the mortality. Some guidelines like the WHO suggest, so this is a weaker recommendation, suggest not to use it in hospitalized patients, and because the outcome is controversial. The ITSA and NIH, they suggest you can use it for hospitalized patients who require oxygen. Again, did not reduce mortality in some studies, except in the low flow supplemental oxygen. WHO don't recommend it because they had this solidarity study that looked at it and they didn't see any difference in outcome. Multiple studies, well, some show faster time to recovery, and the only time it showed mortality benefit if they have if they require low flow oxygen. So many studies looked at the 5 days versus the 10 days for the remdesivir. And even a study that was done by the company itself showed 5 days is somewhat better, but this was open label and wasn't randomized. Okay, they looked at remdesivir for mild and moderate who does not need oxygen and their SAT is above 94. So they really don't have hypoxemia, SAT 95 or above. And 5-day remdesivir in this group had better clinical status, but this study had some confounders. Other study did not reduce time to recovery, so very controversial. So the strongest recommendation for patients who are requiring low flow oxygen. What is the common side effect? These are the common side effects of remdesivir: anemia, acute kidney injury, fever, hyperglycemia, elevated transaminases, but one study showed they are similar to controls. One study showed that they are higher than controls. Also, some reported bradycardia from remdesivir. So a patient is on remdesivir and they are bradycardic and you don't know the reason, consider remdesivir as the cause of their bradycardia. Not preferred to be used in patients with GFR less than 30 because this can be harmful. Although some people think we are giving it only for 5 days, even with renal impairment, you can give it, but most of the people don't give it for patients with renal impairment. You need to follow liver enzymes, check it before you start it, follow it every day until you are done with the remdesivir. Adding baricitinib to the remdesivir. So baricitinib is a Janus kinase inhibitor, and this mainly used for some rheumatological diseases as rheumatoid arthritis. The main thing that you can use it in addition to the remdesivir in patients with severe and they are not able to take the steroid for some reason. May reduce the recovery time, and mainly better to use the remdesivir and the baricitinib for patients with contraindication to use the steroid. There's some issues about the possibility of increasing thrombosis, although data is controversial for that. So maybe baricitinib is not the best use for somebody who already has DVT or PE or so. Again, trend towards lower 29-day mortality, but wasn't statistically significant. And in general, some observational studies showed lower rate of death, but these are just observation, not randomized controlled studies. How about tocilizumab, which is IL-6 pathway inhibitor? So tocilizumab is better for sicker patients, mainly patients on high flow oxygen and higher. High flow oxygen, invasive ventilation or so. Then you can use it for patients on low flow oxygen case by case if they have very high inflammatory parameters, and you can consider that like CRP more than 75 or so. Don't use it without the steroid. You should use it with the steroid. It's better to use it early on admission, within 24 to 48 hours of admission to the ICU. Again, some patient, if you have significant bacterial infection, it's not preferred to be used, although the data showed no increase in the infection. But if your patient is severely immunocompromised with ANC less than 500, thrombocytopenic, ALT is more than 5 times. By the way, you need to stop the remdesivir if your enzymes are 10 times higher than normal. Here, if enzymes are more than, especially the ALT, more than 5 times the upper level of normal, don't use it. And there is risk also for GI perforation with that. The dose, single dose, 8 milligram per kg. Overall benefit, there's some mortality benefit with the tocilizumab with the steroid. NIH and ITSA and the National Health Service in the United Kingdom, they all recommend adding that to the dexamethasone in severely ill patients. Okay, reduced the 28 mortality. For patients who are not on mechanical ventilation, they also had reduced progression to be on ventilator or death. So the serious adverse effects are mainly infections because it reduces the immunity. Convalescent plasma studies all over the place. We heard before it's better to use convalescent plasma with high antibody titer. Some data doesn't differ between high titer, low titer. Some suggestions not to use it unless you are in a study or so. We used to give a lot of plasma. I think I had a report from our hospital recently, only one patient got it who was not on the ICU in the last week or so. We used to give every patient who comes to the hospital convalescent plasma, but now our use significantly reduced based on the recommendation. Things may change in the next few days, but anyway, many studies with controversy for the convalescent plasma did not detect any difference, no difference. Higher antibody titer had earlier presentation are associated with greater clinical effects. So data is very controversial, but all the guidelines recommend not to use convalescent plasma unless you are in a study or so. Okay. Monoclonal antibodies, and probably you know about that more because this is mainly recommended for patients with mild and moderate who do not require hospitalization. But if your patient comes to the hospital with mild to moderate COVID pneumonia, but they came for something else, so like he fell and fractured his hip or something like that, you can give the monoclonal antibody as inpatient. It's mainly for treatment for outpatient for mild and moderate COVID, and that have specifically certain risk factors to go to severe disease. It reduces combined need for hospitalization and death for these people. I know everybody heard about ivermectin. Many countries are using it. Some studies showed benefit, but these studies had a lot of confounders that may have affected the results. So the recommendation here in the US not to use the ivermectin. I'm sure everybody heard this discussion about vitamin D. So some data that vitamin D deficiency increase the possibility of having COVID, having more severe COVID. Patient in the ICU specifically at higher risk to have vitamin D deficiency. So they will benefit mainly if you have low vitamin D levels, okay? So should you use it or not? It's okay to use, but don't use high dose because some data suggested to use very high dose. So you should use the normal dose, 600 to 1,000 international unit daily of the vitamin D. But don't use very high dose. And especially if your patient has low vitamin D level or on the ICU, you will consider using the regular daily dose, up to 1,000 units a day. There is no association between mortality and vitamin D, so it will not help the mortality, but it's okay to use. No data for zinc and no data for lopinavir. Recommendation is not to use lopinavir. Last thing I'll talk about is DVT prophylaxis for patients with COVID-19. Also, the data are changing very, very, very frequently. Every few weeks, we have different data, different studies, and the recommendation. These are some websites I would like you to look at for the DVT prophylaxis recommendation because they change very frequently. But for now, for all hospitalized patients, we need to put them on DVT prophylaxis. Any hospitalized patient with COVID on the floor, on ICU, or low flow oxygen, on high flow oxygen, on BiPAP, on ventilator, all of them should be on DVT prophylaxis. Anybody admitted to the hospital with COVID-19 should be on DVT prophylaxis because of the high risk for the DVT-PE for these patients. Also, it's not just DVT-PE, they have higher risk for coronary thrombosis. A lot of studies looked at prophylactic dose versus intermediate dose versus full anticoagulation, and data are very controversial. The up till now recommendation, you have to use the prophylactic dose, and the preferred is low molecular weight heparin enoxaparin, and the dose is 40 milligram once a day, and you need to correct that for BMI. For patients with BMI more than 35, you may need to have higher dose. And this table from up to date will tell you based on the BMI what dose you should use to be enough for prophylaxis. You can go up to 60 milligram every 12 hours. This is prophylactic dose for somebody with BMI more than 50. Again, a lot of studies for the dose. Intermediate dose, they use 1 milligram per kg daily versus 40 milligram daily, and they looked at the comparison. They looked at prophylaxis versus full anticoagulation, and some data showed that full anticoagulation is better to reduce DVT-PE, but higher possibility of bleeding. So variable data for that, but at least put everybody comes to the hospital on DVT prophylaxis with low molecular weight heparin, unless they have significant renal impairment or if they have HIT, then use some other medication. Fondaparinux was recommended for patients with HIT if you will use prophylaxis or therapeutic. If your patient has renal impairment, you can use heparin sub-Q. Here the recommendation that don't make changes if you based on your D-dimer, because at a certain time when you had high D-dimer above 1,000 or some people use above 5,000, we started full anticoagulation. Don't use anticoagulation, full anticoagulation based on the severity. Just also, I would like to let you know that some of the patients may have heparin resistance, and PTT may not be helpful if you are on heparin drip or so. They recommend in this condition to use antifactor 10A activity level to determine the proper dose for that. Okay, one other last slide I would like to tell you, because I didn't know that initially, then I was reading and found this. So don't give any vaccine to your patient within 2 weeks of the COVID vaccine. So if your patient needs pneumonia vaccine and he got his COVID vaccine last week, or he will get his COVID vaccine next week, delay your pneumonia vaccine. Same thing for flu or other vaccines. Okay, so take-home messages. Management of the pneumonia depends on type of pneumonia. Is it community-acquired, ventilator-associated, or hospital-acquired, or COVID pneumonia? Community-acquired pneumonia management will differ if you are treating the patient as outpatient or on the floor or in the ICU based on the severity. You need to send the proper labs, start the proper antibiotics, and for the proper duration. Okay, any questions?
Are there any recommendations for continuation of DVT prophylaxis for patients who had severe COVID and are discharged?
There is nothing about that. I didn't look at the outpatient, but I didn't hear about strong recommendation to continue the DVT prophylaxis as outpatient. Although they say should be assessed case by case, because patient that probably will be bedridden or something like that after discharge, you don't think they can ambulate much. It may be reasonable to put them on DVT. Patient who is young, healthy, doesn't have any risk factor for thrombosis, going home feeling better, he's out of the window of isolation, can move all around. You may not need to put them on. If your patient is on anticoagulation before admission, so say if he's on anticoagulation for AFib or something, or previous DVT PE, you will need to continue full anticoagulation for this group. So this group, you need to continue full anticoagulation for. I may need to look back if there's any specific guidelines for the discharge, but usually not. But I may need to look back because things change every few days, as I told you. And I have this slide that I showed to you that has 7 or 8 websites for anticoagulation recommendation only, just for anticoagulation for COVID. And they have also one website with frequently asked questions, and they answer the question.
Is there a time frame to use remdesivir?
Remdesivir?
Yes.
What's the question about?
Is there a time frame we can use it? Like, for example, if the patient had symptoms of COVID starting from 20 days ago and he presented to the hospital.
There are some studies that suggested if you use it within 10 days of the symptoms will be better. And other studies showed no difference if the duration is less than 10 days or larger than 10 days. But the main people that will benefit from it for sure if your patient is on low flow oxygen. So if the symptoms is more than 10 days and he's on low flow oxygen, I may start it. Make sense? Because there's some benefit, mortality benefit from that. And the data about the duration before 10 days or after 10 days is very controversial. Some people use higher dose. I showed you the study for the ARDS, and some of my partners even here, they like to use the higher dose, the 20 milligram and 10 milligram for the dexamethasone, 5 days 20 and 5 days 10 if the patient have ARDS. So based on this Spain study that I showed you in the lecture in the morning. I probably will send you some more, Bree, I think, and Tani sent you some articles to read. I have some more articles we'll send to you to read and ease. And mainly for the COVID, I want you to read the management guidelines every couple of weeks or so, because they may change. Pick one that you like, look at them, pick one that you like and go for it. Or all of you have access to UpToDate. They update every week or so. When I prepared this study, it was last updated on April 30th, so very soon, and some things were like April 27 or so. So they update very frequently. So, any other questions about the pneumonia, or any question about anything that you heard about since we started the course? I know 5 hours in the afternoon is tough, but this is the only time that we can coordinate between the work, and you will have the recorded course maybe early next week will be available for you on the SharePoint, and you can review that, but don't delay that till 6 months later. It may not be available at that. We'll try to find a way to try to save it for the whole year until we get the new course next year. But up till now, if you would like to repeat it, you can record it on your phone or so, if your phone has capacity for 15 hours video, I'm not sure, or on your, anyway. Great, thank you very much all for your attendance, for your participation, and I have very positive responses from all the lecturers that gave you lectures yesterday and today, including myself. So thank you very much for that, and have a good day.
Thanks,
Thank
Dr.
you.
Gohar.
You're welcome.
Thank you, Dr. Gohar.
You're welcome.
Thanks.
Thank you.
Thank you.
You're welcome.